Доброе утро, уважаемые коллеги! Мы вас приветствуем в виртуальных стенах Российской медицинской академии непрерывного профессионального образования. И сегодня мы начинаем очень интересное мероприятие. Это международное мероприятие, международный онлайн-семинар Cochrane Россия, кохреновские систематические обзоры, надежные доказательства для мудрых решений в медицинском образовании, науке и практике. Уважаемые коллеги, это уже наш традиционный семинар на площадке Российской медицинской академии непрерывное профессиональное образование. Он второй, и это не случайно, потому что более года именно на базе Российской медицинской академии непрерывное профессиональное образование функционирует Cochrane Россия, отделение Cochrane в Российской Федерации. Это очень важно, потому что именно дополнительное профессиональное образование врачей является мостом между доказательными, надежными доказательными знаниями и реальной клинической практикой. И это мы транслируем через наши образовательные программы и через образовательные мероприятия, в том числе то мероприятие, на котором вы присутствуете и в котором вы будете активно принимать участие. Я очень благодарен нашим зарубежным коллегам за активное участие в этом семинаре. Они выступят в качестве докладчиков, модераторов соответствующих симпозиумов и обсуждений в группе. Я очень благодарен нашей академии и нашим организаторам за организационные моменты, связанные с семинаром. И перед тем, как перейти к приветствиям в нашем семинаре, я хочу представить своих сопредседателей, прежде всего проректора по международной деятельности и лечебной работе, академика Российской академии наук, заведующей кафедрой онкологии Ирину Владимировну Поддубную и координатора Cochrane Россия и Центра трансляции доказательных медицинских знаний Российской медицинской академии непрерывного профессионального образования профессора Зиганшину Лилию Евгеньевну. Уважаемые коллеги, а теперь с большим удовольствием я хочу передать слово для приветствия академику Поддубной Ирине Владимировне. Пожалуйста, Ирина Владимировна.
Уважаемые коллеги, добрый день. Событие, которое Дмитрий Алексеевич обозначил как уже почти традиционное, ибо не первое, по своей значимости очень велико. Дело в том, что принятие решений в медицине – это очень сложный вопрос. И мы хорошо понимаем, насколько велика роль в свое время созданной Кохрейновской библиотеки, которая является той опорой, дающей возможность глубоко изучить предмет и понять, правильно ли мы двигаемся, чтобы принять то или иное решение. Надо сказать, что кохрейновские обзоры, а именно это является основой сегодняшнего разговора, нашей встречи, очень важны для принятия решений в разных сферах. Медицина, безусловно, на первом месте, но и наука, и образование. И мы, как образовательные учреждения, ставим перед собой очень непростую задачу понимать, насколько точно, выверенно должна быть вся та информация, которая исходит от преподавателей, касающаяся самых разных аспектов. И мне хочется подчеркнуть, что так случилось, что в целом в мире, и это наша страна не исключение, внедрение кохрейновских систематических обзоров изначально и быстро стало внедряться в науку. Именно это направление, это хорошо всем нам с вами понятно. В медицину и в образование это тот процесс, который сегодня есть, он активен, он не столь, на мой взгляд, еще пока завершен и успешен, и здесь есть как раз те направления, которые надо обсуждать, потому что мы хорошо понимаем, что не случайно по инициативе руководства Академии был создан Центр трансляционной медицины, доказательной медицины у нас в образовательном учреждении, конкурирующем все дополнительное медицинское профессиональное образование. И поэтому сегодня мы с вами имеем уникальную возможность при той программе и тех экспертов, которые включены, остановиться на этом аспекте более детально для того, чтобы в дальнейшем мы использовали это с должной эффективностью. Поэтому я думаю, что мы будем с вами активно это обсуждать и желаю успеха нашему сегодняшнему семинару.
Спасибо, Ирина Владимировна. Уважаемые коллеги, Центральный институт усовершенствования врачей, ныне Российской медицинской академии непрерывное профессиональное образование, многие годы активно сотрудничает с Всемирной организацией здравоохранения. Всемирная организация здравоохранения в настоящее время, российское представительство активно поддерживает наши образовательные активности по разным направлениям. По направлению безопасности медицинской деятельности, по направлению трансляции доказательных медицинских знаний. И я с большим удовольствием, с большой благодарностью хочу передать слово для приветствия специальному представителю Всемирной организации здравоохранения Российской Федерации, госпоже Мелите Вуйнович. Пожалуйста, Мелита.
Melita Vujnovic. Good morning, dear Dmitry, dear colleagues. On behalf of Melita Vujnovic, let me apologize for her absence. She's sick today. She has a fever, high temperature. I think it's not what we think. But I would like, on behalf of the WHO, to pass her greetings, and she asked to participate in the opening of this event. As you've mentioned, WHO, for a number of years, is actively cooperating with the Russian Federation, both in the area of increasing the knowledge of scientists and medical healthcare practitioners in evidence-based medicine and factual data, and also is actively working in the area of decision-making process in this field. And one cannot overestimate the importance of verified information that we obtain for different types of our activities. Traditionally, the events in this area were more related to clinical medicine. Therefore, our physicians got used to the fact that all clinical recommendations and decisions should be based on factual data. And there is a grading of this data. And here, and now of great importance, are the databases, which provide complete reviews in the area. Cochrane Library and Cochrane Reviews became the handbook for scientists in many areas. However, I have to mention that more and more we are talking about informed decisions in the area of healthcare, where the evidence base is not so clear as in clinical trials, which are based on certain principles initially. Definitely of great importance is availability of this knowledge and understanding among physicians, including through the establishment of continuous education. As for WHO activity in the area of increasing information and spreading factual data, that will be covered in detail by our colleagues from the regional office. Therefore, I will not dwell on it. However, I'd like to say that Cochrane Russia is hosting it's hosted in the oldest establishment for continuous education in Russia. Therefore, it's of great meaning for us, and we wish every success to this seminar and hope for further cooperation in this area. Thank you. Thank you, dear colleagues. On behalf of the Russian office of WHO and Melita Vujnovic, Dr. Yelena Yurasova addressed us. She's the coordinator of non-infectious diseases of the Russian office of WHO. Yelena, thank you. Thank you for your presentation, for your support. Please pass our best well wishes to Melita. Dear colleagues, we proceed, and the next greeting is the editor of publishing house, edit-based health care publishers, Deborah Pantesco.
Good morning.
Доброе утро. Доброе утро и спасибо и поздравления. Какая честь быть с вами сегодня в этот самый важный день, в самом важном мероприятии для доказательной медицины, Cochrane Russia, важный день для образования, для ученых и для медиков. Меня зовут Дебора Пантеско-Мерфи, я являюсь редактором и издателем Cochrane «Доказательная медицина» Wiley. Wiley — это издательство, которое расположено в Великобритании. Wiley был партнером Cochrane с 2003 года, а я с 2004 года работаю с замечательными коллегами по всему миру, включая Россию, для Cochrane. Мы недавно возобновили это партнерство, и оно продлится до 2030 года. Поэтому мы ожидаем отметить новую эру издательства, исследования и связи между исследователями. Cochrane независимые, высококачественные обзоры никогда не были более важны. И они, кокрейновские обзоры...
And improving global healthcare. So we're delighted and congratulate the Academy as the new home for Cochrane Russia. We look forward to work with you to further develop and support the important work that Cochrane in Russia has already started, and we look forward to seeing continue, including the translations of Cochrane evidence summaries into the Russian language for non-English speakers. And we hope that together we can build and enable access to Cochrane evidence for more users in Russia through national access to full text of the Cochrane Library. As we believe, and we have seen in other countries around the world, that this is in fact the most effective way to build better healthcare evidence decisions. So I say thank you and welcome and enjoy a very important day today.
Thank you very much, Deborah, for your support our event. Thank you. Уважаемые коллеги,
Dear colleagues, and we proceed further, and before moving to our seminar, let me remind you that this is the registered continuous education seminar as educational event. Dear colleagues, our event will include presentations according to the program that you can find on the website of Russian Continuous Education Academy. An unusual element of this program is group discussion that will take place twice at 10:55 a.m. to 11:15 a.m. and at the end of our event 2:45 p.m. to 5:05 p.m. Dear colleagues, this is an extremely interesting discussion where we are able to discuss and state our opinion on the number of issues related to introduction of evidence-based data in the medical practice and using them for wise and best solutions. At the end of our discussion, we'll have a very pleasant opportunity as agreed with the organizers of Cochrane seminar. I will bestow the diploma of the honored professor of the Russian Academy of Continuous Education to outstanding person, Dr. Harold Lipman, who is cooperating with the Russian healthcare for many years, supporting it in the area of healthcare and pediatrics, being the senior advisor of the Foreign Ministry of the United Kingdom. So nobody will object if we'll greet at the end Professor Lipman, and we expect two more professors who are friends of our academy, Nelly Kobzin, chair of Moscow Medical Dental University, and Professor Osmanov, the chief clinical physician of Tushino Hospital, and that will be the end of our today's event. Dear colleagues, and we pass to the implementation of our program. The details of group discussion will be stated prior to this section as well, and you will be instructed as how to join the groups. We have taken care of everything, don't worry. And then for further implementation of our program, I pass the floor to Juhul Jorgensen Karsten, will present on the value of evidence-based Cochrane world experience. He's the professor of the University of Southern Denmark in Copenhagen, Denmark. Professor Jorgensen.
Yeah. Hello, thank you very much for this kind invitation. I'm so sorry that we couldn't do this in person. I have a long history with Cochrane Russia and have had the privilege to visit a few times for workshops. So quite disappointing that we cannot meet again. But Lilia has asked me to talk a little bit about the value of Cochrane evidence, and particularly the value in a global perspective. If we go back to the very beginning, the roots of Cochrane comes from this man, Archie Cochrane, who sadly didn't live long enough to see the establishment of our organization, but he wrote a very influential book in 1972, and gave us all a challenge, namely to use the evidence that we have in the best way possible, having critical summaries updated periodically of all the randomized trials. Because if we do not know what is out there, what information and knowledge is available, it will not be put into practical use. And we need to have standardized ways of summarizing and quality assessing the available evidence. I think that the best way to illustrate the importance of Cochrane evidence and synthesized evidence is probably to give you a very concrete example, tell you a little story. I'd like to start with showing you a picture of a set of twin girls. These twins were born 2 months early, like many twins. That can cause us a series of complications, mainly related to airways and breathing. And for a long time, there was a discussion whether mothers should be given corticosteroids prior to threatening premature labor. And a number of trials were conducted, and these trials were summarized in one of the first meta-analyses in medicine by Ian Chalmers for the world's first evidence-based textbook, which he was co-author of. And you might ask yourself, so what were textbooks based on, if not evidence in the past? But what set this textbook apart was that all treatment recommendations were based on systematic reviews and meta-analyses. And that led to a register of systematic reviews in Oxford that were later expanded to other clinical areas and eventually became the Cochrane Library. That's actually the meta-analysis that's depicted in our logo. So the vertical line indicates the line of no effect, and the horizontal lines indicate the confidence intervals, the 95% confidence intervals of the individual trials. When that overlaps the line of no effect, the result is not statistically significant. And when it doesn't overlap the line of no effect, we have a statistically significant result. At the very bottom, you can see a diamond-shaped symbol, and that represents the summary estimate. And you can see that that summary estimate here does not overlap the line of no effect. So we have a statistically significant beneficial effect overall when you summarize all of these trials. And that is a hugely important result, because the outcome that was measured in this meta-analysis is perhaps the most important outcome in all of medicine. It is child mortality. What we are measuring in these trials is the number of dead children. And that outcome and that particular meta-analysis was of particular importance to me because the twins that you saw in the first picture are in fact my daughters. And you can see a picture of them here. And I think they turned out rather well considering their offspring, their origins. Of course, when I started out working for Cochrane almost 18 years ago, I had no idea that 8 years later, I would need the most quintessential piece of Cochrane evidence. And I think there is a specific point in that, because we're all going to need evidence at some point, either for ourselves or for the ones that we love, or for our patients. But we're all going to need this evidence. We don't know what evidence we're going to need, but we are going to need evidence at some point in our lives. So we had a rather complicated period at that time around my wife giving birth. There was threatening preterm labor, and one of the things that was suggested by the doctors at our hospital was cerclage. So basically tying a piece of string around the cervix of the uterus in order to prevent premature birth. So, of course, I looked up the evidence, and fortunately enough, there is a Cochrane review on that. If we look a little bit at the results here, we can see that there is actually 6 randomized trials that assess this intervention. A total of 2,175 women were included in these trials. Based on this evidence, the authors concluded that there was no overall reduction in pregnancy loss and preterm delivery rates. So no beneficial effect of this. But what they did find was that it was associated with mild pyrexia. And of course, all these interventions, all interventions have a risk of harm. And in this case, of course, it's infection. So in addition, there was an increased use of tocolytic therapy and hospital admission. So it's not risk-free, but it didn't seem to be supported by evidence that there was a benefit. So I talked with the treating doctors about this, and we agreed that my wife should not have this intervention. They then went on to suggest strict bed rest. And it really is strict. You were not allowed to go to the bathroom or take a shower or go get yourself a drink. And this could go on for weeks, even months. So, of course, you can immediately understand why you would think that might be beneficial. You take the load off of the pelvis. But you can also foresee that there might be some consequences, negative consequences. It's rarely healthy to be lying still in bed for prolonged periods of time. Certainly increases the risk of thrombosis. And of course, pregnant women are already at an increased risk of thrombosis. And it also weakens the body in general, which is probably not a very good idea either, with labor being on the menu. And then, of course, there might be some psychological consequences of being confined to a bed for a prolonged period of time. So I looked up the evidence again, and fortunately, there is a Cochrane review. Even for a Cochrane review for this particular intervention in multiple pregnancies. So it couldn't be better. And here we have 5 trials, 495 women, 1,016 babies, so some must have been triplets. And again, there was no risk of very preterm birth. Unfortunately, none of these trials really reported on harms, and that is a problem we often face as treating clinicians and systematic reviewers, that the data on harms of the interventions is often sparse, not reported very well in the trials, although the harms of interventions, of course, are as important as the potential benefits, and you need knowledge about both of these to be able to make an informed choice. So I talked with the treating doctors about this, and they still wanted to go ahead with this particular intervention. I've later learned that now they have stopped using it, but you can't win all the arguments, of course, even if you can back your arguments with Cochrane reviews. So as you can probably imagine, by now I was considered the relative from hell, but we were able to make friends, and I actually ended up doing a Cochrane review with one of the treating doctors on another intervention that he identified as important, and that is the way most Cochrane reviews is done, a collaboration between clinicians and methodologists like myself. We need the clinicians in order to identify the most clinically relevant questions to do Cochrane reviews on, and then we need the methodologists to assist the process of systematic reviewing. And these collaborations are at the heart of our organization, and ensures that our reviews are clinically relevant and important to patients and clinicians. We also do systematic reviews that are commissioned. This review was commissioned by the WHO for the COVID-19 pandemic, and I never thought I would do a review on hand washing with ash. You need people who know what questions to ask in order to do relevant reviews. And what I didn't know was that about 40% of the world's population do not have access to running water and soap. So potentially, of course, this could be a hugely important review in order to control spread of not only COVID-19, but all sorts of infections. So we did this one for the WHO. We also did a scoping review for the UK government. And I think Cochrane will, to an increasing extent, be doing reviews at specific requests from end users. And I think that might be a good thing to some extent, because we do need to produce reviews that are needed by either clinicians or institutions that make guidelines and guidance and set policies. So what makes Cochrane reviews special? Well, our organization was the leading organization to introduce the method of systematic reviewing and needs analysis into the medical field, the field of medicine. And we are still the leading organization when it comes to developing these methods and bringing them into practice. We were the first organization to highlight the importance of having published peer-reviewed protocols for studies. We're probably still one of the only organizations that peer-review protocols. But this was also groundbreaking when we started to do that. We are the first organization to have really strict criteria for the number of authors that are allowed to have conflicts of interest, and their placement in the role as authors. So first and last authors cannot have conflicts of interest, and only a third of the authors are allowed to have any conflicts of interest. Usually it's considered enough to declare your conflicts of interest, but that doesn't really solve the problem, in my opinion. Your possible intellectual and financial biases does not go away because you declare them. We do reviews based on really strict criteria that's set out in a rather thick volume called the Cochrane Reviews Handbook. And we are the leading ambassadors for evidence-based medicine. We are facing some challenges as an organization. We need to increasingly use clinical study reports, which is the data material that drug regulatory authorities use in order to do our systematic reviews. We need to do more to ensure that our reviews are timely and clinically relevant. And one way of doing this is to use what's called living systematic reviews, where you continuously update the reviews as new evidence is published. And indeed, living network meta-analyses. Network meta-analyses being comparisons between interventions where you do not have head-to-head randomized trials available. We also need to ensure that authors have a good experience when they publish through the Cochrane collaboration. Currently, it takes too much time and it's too complicated. So we need to have uniform standards for this across our organization, and we need to simplify the process of publishing Cochrane reviews. Currently, it takes an average of 2 years to publish a review, and of course that is a problem in terms of keeping our reviews timely and up to date. Another example, and I'll just briefly go through this. I'm sure you've all been having discussions about whether face masks are of any value or not, and the health authority in my country did actually a really good report on this, but they were faced with the same problem as everybody else, which was conflicting evidence and evidence of suboptimal quality. So there were mainly 2 systematic reviews that they could use. There was a Cochrane review, that's this one, which was published first online. This is like preprint, based on the randomized trials, and it found that the available trials seemed to show that they made little or no difference. On the other hand, some very skilled methodologists, some of them are behind the grade methodology, did a systematic reviews of based on observational studies published in The Lancet. And in the observational studies, they found a huge effect, 50% reduction. So what do you do then? I think both reviews probably were correct in their assessment of the available evidence, but it was different evidence bases and quite different results. So based on the observational studies, a group of Danish researchers then designed a randomized trial aiming to identify this 50% reduction in infection rates. And they couldn't find it. They did not find a statistically significant reduction with face masks. There was probably a difference, but it wasn't large enough to be statistically significant, and it was probably quite a bit smaller than what was seen in the observational studies. So again, uncertain evidence, but you still have to make a recommendation. You still have to make a decision. And some organizations were very quick to do this. Here we have the CDC in the United States, who assessed that there was now compelling data to support the use of face masks. And if we look a little bit about on what they assessed as compelling evidence, we can take a look at the schedule. Of course, I'm not going to go through the whole thing, but if we just look at the first study by Hendricks et al., you can see that this was a study that took place in a hair salon in Springfield, Missouri. 2 hairstylists and 139 customers. And the 2 hairstylists were infected and symptomatic, but wore face masks. But none of the customers that they assessed were infected. Of course, they were only available to assess 67 of the customers, and the customers that would have been infected and possibly died from COVID-19, of course, you couldn't follow up very well. So usually we would not consider evidence like this worth its salt, but in a politically tense environment, standards can drop. It's just to say that we are it's an example of conflicting and suboptimal evidence in a situation where you still have to make decisions and make them quickly. And that is a challenge for evidence-based medicine, but we are trying to meet that challenge as best we can. Now there is a new randomized trial from Cambodia, which seems to indicate that there might be some effect of masks. They randomized villages, 600 villages, 350,000 adults, and identified 9% decrease in infection rates, which just made statistical significance. So there might be a small effect, but we probably shouldn't base our whole strategy on face masks. In absolute terms, relatively small effects. 1,587 fewer were symptomatic out of 175,000 who were instructed in using face masks. And about 103 of those 175,000 avoided being positive for antibodies. So quite small effects, but of course we're talking about exponential growth here. So it might be relevant, but we probably shouldn't expect too much. So systematic reviews sit at the top of the hierarchy of evidence, and they are pivotal to decision making, also in acute situations. But you can reach quite different conclusions based on what types of studies you choose to include. So my last example is to exemplify that evidence isn't always enough. We did a systematic review of health checks, and reactions to that were quite different. We got quite a lot of attention in the UK because they just introduced a systematic program for health check program. And I know that you're all looking at this wonderful spontaneous family photo on the right, but it's actually the text on the left that's important. And we could say quite clearly that the evidence told us that this did not have the desired effect. But in the UK, where they just introduced this program, the reaction was to refute the evidence and say that we know it works because we base our program on expert guidance. And expert guidance, as you'll probably have noticed from the evidence hierarchy, is at the very bottom. Experts are not very reliable, particularly if they don't use the best available evidence. On the other hand, in our own country, our then health minister said that they had now put the original suggestion to introduce health checks on ice because it does not have the desirable effect. So whether the evidence comes before or after the political decision is made is quite important. So evidence is one thing, but politics include other considerations. And it's not always enough. So just to give you a brief overview of the evidence, and the way we do that in Cochrane reviews is summary of findings tables. And you can see here that we had access to 11 randomized trials, including almost 250,000 people. And for the most important outcome, total mortality, there was absolutely no difference, a relative risk of 1.00 based on high certainty evidence. For those outcomes where you really expect a benefit, all of these programs targeted cardiovascular disease. Again, we saw no effect of the intervention based on a substantial number of trials with a large number of participants, high quality evidence. But it wasn't enough in some cases. So Cochrane is based on contributions, that you contribute an effort and then you gain membership. And there is a few ways that you can contribute. There's something called the Cochrane Task Exchange, where you can offer your help, doing translations, doing data extractions, whatever would fit your skill level and the time you have available. You can go to a Cochrane colloquium, or at least you can when COVID-19 is over. And then, of course, you can do a Cochrane review as part of your PhD, maybe. It's always a good idea to do a systematic review before you do a trial. And Cochrane reviews are a very good basis to plan a trial. So that is also an option. So yes, I think that's it from me. So thank you very much for listening.
Спасибо большое, Карстен, за очень...
Thank you very much, Karsten. Thank you for a very, very emotional and memorable talk. Thank you very much for giving us examples how the knowledge is used to make decisions. And it was a great illustration when you talked about masks and when you talked about health checks. I would still say that we should all wear masks. By the way, Professor Jorgensen contributed a lot to the development of Cochrane Russia. He was one of the organizers of Cochrane Russia, and he supports Cochrane Russia in the system of continuous medical education in Russia. Dear colleagues, you can ask your questions on the chat, and we will answer your questions during the discussion part. Karsten will join us one more time when we move to the discussion. Next, in our program, we have a very interesting talk from a representative of the WHO.
The representative of the WHO.
Concept Evidence for Healthcare Policy. This talk will be delivered by Margaret Reynolds, who is a magistrate in public health, coordinator of Europe-Net, evidence to inform healthcare decisions. She works in the country departments and in the European Policy Department.
Доброе утро. Good morning, everyone. Apologies for speaking in English, потому что мой русский язык не достаточно. I hope that next time we will be able to
in English,
converse in Russian. I'm delighted to be speaking with you, and as Karsten, maybe hoping that next time we will be meeting in person in Moscow. And as said, so I will be sharing the WHO support and ideas on how we ensure that the best available evidence, as Karsten earlier said, is used to policy and other decisions. I will be still sharing my screen with Russian slides.
Поделюсь экраном
but I will be looking at
с русскими слайдами. Но я буду смотреть на свои заметки по-английски. Видите ли вы мои слайды?
Good.
Хорошо. Итак.
I will be going a bit through the context that what is the no-do gap, what is the evidence-informed policy making and making decisions based on evidence, then going through a bit around that how WHO supports countries and responds to country needs, because we all want that evidence is the most normal thing to go to when the decision makers, not only politicians, but also health authorities, clinicians, organizational leaders, will go to before they start making decisions. As well, then give you a few examples of our country work. So what is the famous no-do gap and how we can bridge this? So kind of couple of examples based on one of the earlier studies, but I'm sure that the numbers are similar even currently. The study found that 30 to 40% of patients in United States and Europe do not get access to cost-effective, they don't receive the cost-effective health interventions. As well, 20 to 25% patients get care that is not needed or potentially harmful. And this, the next speaker will talk more about it. But how to ensure that we get over that bridge? But first, let me go a bit about an analysis or to present some of these key barriers of why this is not happening. And this is based on three systematic reviews. Unfortunately, none of them is Cochrane review, but still it synthesizes the available evidence on key barriers and on translating evidence into policy. And one is that research evidence is not valued in decision making. It's not yet the most normal thing to go to, but also that the research evidence is not accessible, it's not relevant, and easy to use in decision making. And what we have also seen in our countries where we have worked is that one of the barriers is a language barrier. And here our collaboration with Cochrane Russia and the work that they do is highly valuable in bridging that barrier. Also that decision makers, be it politicians, organizational leaders, but also clinicians, they lack skills to find, interpret, and understand evidence. But also there is lack of personal contact and opportunities for researchers and decision makers to interact, to really understand each other's needs and how they can build on each other's skills and work. And also lack of funding. As an economist myself, I would say that money has not run out in the world. So it's basically more of a question on priorities and reallocation. But also if we provide services to the patients and have cost-effective best buys implemented in policy, then there are also cost savings. But how to overcome the barriers? And in these systematic reviews, also the ways forward or these ideas on how to break those barriers, and one being obviously collaboration between researchers and decision makers, building relationships, building so-called knowledge translation platforms where evidence can be synthesized and fed into the decisions, but also improving access, availability, and timely access to research evidence. And there also Cochrane has an enormous role to play in building capacities, not only personal capacities that we and the decision makers know how to use evidence, but also that there are processes and structures in place. And also the relevance that the research community has also a role to play in terms of producing the research evidence that is relevant for those who need them. And how to bridge the gap. And then through the process of knowledge translation, it really is a process where you understanding each other's needs and having the platforms in place where you are, it's possible to ensure that the available best evidence is incorporated in policy development or decision making, as well as that policy priorities are taken into consideration in research efforts. And it's very important that it's not to do for the sake of doing, but the aim of this mutual process is to really improve the health systems and strengthen health systems and improve people's health. And just let me give you the most used definition of evidence-informed policy making. And it really is that instead of opinion-informed policy decisions, we advocate strongly that evidence-informed approach needs to be taken, because only then we know what works and what don't work, and also what is known and what is not known. because we don't have all the evidence and information in the world. And it's extremely important during the pandemic when we also communicate the uncertainty of the evidence. It aims to really ensure that the best available evidence is used. It's available, it's timely, it's credible, it's valid and relevant. The methods and processes used are systematic and transparent and without undue influences. And also it incorporates the products and tools that are frequently called as knowledge translation tools, such as evidence reviews, evidence to decision frameworks, are easy to use and understand, and helping to package that evidence into accessible format to policy makers. And already in 2005, WHO member states proposed a resolution where they asked and called themselves as well as WHO to support them to establish and strengthen mechanisms to transfer knowledge in support of evidence-based public health and healthcare delivery systems and evidence-based health-related policies. As a response to that, an evidence-informed policy network was formed in order to improve the decision-making and support countries. And in 2012, this network, the branch was opened in WHO European region, calling for countries for joint as a pilot countries, and then later on advancing to other countries and supporting many more. And with really the mission as the words and which the best available research evidence informs policy making. Basically, what I mentioned, that it is the normal thing to do. And there are three pillars of our work. One is the promotion of systematic use of research evidence and policymaking to improve health systems through a network structure. That's why the Dandelion showing a bit of structure, as well as the cross-fertilization of the ideas and methods and tools, but also working strongly with countries to improve the capacities in knowledge translation, but also institutionalizing knowledge translation to establishing knowledge translation platform. And this work is also supported in the new European program of work, United Action for Better Health in Europe, that was approved last year, that aims to support and build capacities, development of policies and practices that are grounded in evidence and factual information. And now a bit about the structure. We do have a secretariat in WHO regional office where we bring members together, empowering the countries, hands-on providing assistance, tools, but also the network is supporting the team members and peers and sharing experiences and lessons learned. One of the approach that was taken early on is to really work dedicatedly in some countries, starting with developing the situation analysis. Here you can see some of the countries from Estonia, Kyrgyzstan, Poland, Slovenia, who have done their situation analysis, understanding the capacities and already existing structures on what it is possible to build the capacities and the institutional structures of knowledge translation, and understanding better, but also discussing with different stakeholders who could bring their experience as well as take on the work. And here you can also see the published articles on Hungary that addresses some of these barriers and possibilities. The second stream is really the capacity building. Here you can see one of the last, actually the last in-person country meeting, multi-country meeting for Eastern European and Central Asian countries, where Cochrane Russia provided excellent input and support to harness the evidence in Russian language that is there. And it really brings together our EVIPNet member countries and enhances the network-wide collaboration, but also economies of scale, of capacity building. And here we really focused on supporting countries and developing rapid response service, and how rapidly in times of urgencies and timely need for the policy processes, it is possible to find systematic reviews and still be systematic and transparent in providing policy solutions to the critical questions. But we also have country-specific track of our capacity building, where we have national training workshops to countries on concrete skills that has been identified as critical, but also really hands-on technical assistance to countries to support particular development of particular topic, developing the policy options around particular topic, to provide these evidence brief for policies, and followed by policy dialogue among stakeholders to really discuss these evidence for certain policy problem that is considered as a priority. We do also, to support our work and countries, have a work stream where we develop tools and innovations. Here you see the selection of already published tools in terms of how to develop evidence brief for policy, which bases mostly on systematic reviews and harnessing the evidence to provide evidence overview of a policy problem, but also situation manual of how to organize policy dialogues, but also there are a few additional tools in the pipeline to develop a better tool to assess the country capacities on evidence-informed policy making, on how one can do rapid response in a transparent, systematic way, and still harnessing the best available evidence, as well as the guideline adaptation to country context, as well continuing the systematic and transparent processes, which I'm really stressing several times here. We don't work alone. We have a strong support network in the middle. We really rely and work closely with the partners in Cochrane to overcome the barrier of using the evidence, having better access to evidence, and really in our specific region, the Russian language, which I feel I still need to bring this back and be more fluent, but it also barrier otherwise that most of the global published literature is in English, and so the valuable work on Cochrane Russia needs to be commended, and we from our side would really would like to formalize our relationship and maybe consider even a WHO collaborating center in this area and to support really the countries that are in need, but also work with Cochrane as well as Research for Health, who is a WHO initiative that opens the access of international journals to countries in low need, as well as the already existing collaborating center and McMaster University and Knowledge to Policy Center in Lebanon are great supporters in terms of the conceptual and work, as well as the facilitation of some trainings. But also in COVID, we are working with international consortiums and groups to improve the access to rapid evidence to our members on COVID-related questions. But how we do that, it's really taking the integrated knowledge translation approach, really impact-oriented, country contextual, starting with the priority setting to inclusive and participatory process. So here we really rely on, as I said, knowledge synthesis and rather than and knowledge production, working on systematic reviews, packaging and knowledge translation tools such as evidence-free for policies, rapid response, but also working on knowledge uptake via citizen engagements and advocacy, which we see that it leads to better policies and better health outcomes. Now, quickly, 3 cases. So one is where we combined our efforts with antimicrobial resistance team, providing capacity building through 3 cohorts of countries. We have already 4 evidence-free for policies, already some impact in terms of curriculum changes and changing practices, and then 6 in publishing and review processes. And last week I was on Greece on a policy dialogue and discussing their ways on how they improve hospital situation and antimicrobial resistance. Then secondly, Hungary, it started as a pilot country with situation analyses and also last week discussing the ways on how they can strengthen their evidence-informed policy making through establishing rapid response service. And thirdly, the Uzbekistan, where last year we had a training, again, together with the Cochrane Russia to work on evidence-free for policies. We established a team of multidisciplinary nature with oncologists, hematologists working on childhood cancer to improve the childhood cancer delivery in Uzbekistan. And it really had already an impactful bottom-up policy making that has led to the decree on improving childhood cancer in Uzbekistan. It was a presidential decree, as well as smaller changes in terms of establishing a specialism on hematology oncology for children. And just a quote from the Deputy Minister of Uzbekistan, who really supported and had a political will to and saw the value of evidence hands-on building approach and support in their effort. In November, we had Evidence to Policy Global Summit, which ended with the EBIPNet call for action. And here are 3 areas of work which really is aligned to what we do. So we aim to strengthen our efforts to improve the country capacities across the global. And then finally, the challenges and barriers in evidence-informed policy making are real. There are ways and approaches to overcome them, and it helps to improve the policies and practices, and we, as with our partners, are committed to support the countries. And spasiba за внимание. Thank you.
Спасибо большое, Рейна.
Thank you, Ms. Margaret Reynolds, for the presentation. Thank you for your help, for your support, and for your suggestions for further cooperation between Russian Medical Academy of Continuous Education on the World WHO. The issue of the creating of the Center of Cooperation with WHO will be discussed with Health Ministry of the Russian Federation and will proceed further to this respect. Thank you. Dear colleagues, we proceed, and the next presentation is by Dina Muscat-Meng, Master of Arts, Coordinator of Cochrane Site for Sustainable Development, Cochrane, Denmark.
Thank you very much for that presentation. Hi everyone, my name is Dina Muscat-Meng from Cochrane Sustainable Healthcare. Thank you very much for giving me this opportunity to talk about our new field at your workshop today. I have also been given the opportunity to do my presentation with Russian slides, and I have kept a rather unorthodox approach by keeping my commentary in English below so that I can keep the flow of the slides intact with what's being presented. Yes, so I'm here today to talk about Cochrane Sustainable Healthcare. We were registered as a new field in December 2019. One moment, please. A Cochrane field, I should say, focuses on areas of interest across a number of health topics, and we aim to work with a broad network of collaborators to help advocate and promote the use of evidence to ensure a more sustainable approach to healthcare. We're located at Cochrane, Sweden, under the leadership of my director, Mina Johansson. Our main goals as a newly established field is to enhance the relevance of primary research and evidence synthesis to tackle medical excess, and to increase the use of that evidence to enable more sustainable healthcare for individual patients and societies. We really want to work towards a better evidence base suited to support sustainable decisions about healthcare. We want to develop novel approaches and methods with a focus on tackling medical excess at all points in the evidence chain. Our overall aim is to develop a global network for collaboration on activities ranging from short-term research projects to longer-term reform initiatives. We've outlined 3 priority areas: to develop fundamental reforms to evidence production and synthesis so that harms of medical diagnoses and interventions attract the research attention it long deserves. We want to push for an increased consideration of resource use at all steps in the evidence chain, to arrive at a more sustainable prioritization of resources, both in terms of financial and human resources for societies, as well as of treatment burden for the individual patient. And we want to contribute to the emerging field of how de-implementation and de-intensification is best done, without causing deprofessionalization or counteracting shared decision-making processes. With this slide, I want to present some of the ongoing projects that we have at the moment. Currently, we're collaborating with GRADE on how to increase consideration of medical excess in guidelines. We're evaluating disease awareness campaigns, work that has been commissioned by the WHO, and we hope to develop reporting guidance from this research work. We're also evaluating evidence for individual-oriented lifestyle interventions to improve public health. One of the first projects that we initiated as a field was to look at harms of screening in Cochrane reviews on screening, with the potential to develop core outcome sets for screening interventions. We've also worked on developing our collaborations with key stakeholders such as Choosing Wisely, WHO, and GRADE. And more recently, we've worked on collating a collection of Cochrane reviews on de-implementation. As I just mentioned, we initiated an editorial project to form collections of Cochrane reviews with the aim to create a go-to platform highlighting ineffective or harmful interventions, to generate discussions of these interventions and consequently push for actions to improve sustainability in healthcare. The very first special collection in this series is titled De-implementation of Low-Value Healthcare, Resource Prioritization in the COVID-19 Pandemic Era. This collection was published a couple of months ago. It's primarily aimed at healthcare professionals, policymakers, and guideline developers, and it will be continually updated with new reviews in the Cochrane Library. It was truly an international Cochrane project collaboration with Cochrane Argentina, Cochrane Chile, the Cochrane Methodology Review Group, Cochrane Denmark, and Cochrane Sweden. And we also partnered up with Choosing Wisely to endorse and promote this collection to relevant users. As I mentioned, we will continue to add Cochrane reviews to these collections, and you can see here some of the Cochrane reviews included in the first collection. We hope for this to be a go-to platform for HCPs and guideline developers and policymakers. We're also currently working on establishing a GRADE working group focusing on medical excess. Based on the findings of this work, we aim to develop international guidance for guideline production. We want to advance guideline panels' recognition and due consideration to relevant aspects of medical excess. We've also recently published a podcast with the aim of interviewing thought leaders and sharing knowledge of what they've been doing to make healthcare and health systems more sustainable. This was a podcast that was this was a collaborative podcast with the BMJ, and it was launched last month. I do hope you'll take the time to listen to this podcast. There's some really inspiring conversations here, and a link to the podcast can be found on our website and on the BMJ podcast channel. That's all from me. Thank you very much for listening. If you've any follow-up questions on our work, then please do contact me. You can also follow us on Twitter for recent updates on the work and news from our field. Thank you.
Спасибо, Дина, за интересное...
Thank you very much, Dina. Thank you for a wonderful talk, and thank you very much for cooperating with our academy and cooperation with Cochrane Russia. So we're going to continue our program, and with this, I would like to give the floor to Dmitry Sychov, who is a corresponding member of the Russian Academy of Sciences. He's a professor and our provost. He is the chair of the clinical therapy department of the Vojtech Clinic. He will talk to us about evidence-based medical knowledge as the content for continuous medical education.
Irina, dear colleagues, I will briefly, on concrete examples, will show how we use evidence-based knowledge as the content for continuous medical education. We're talking about both educational programs and educational events. We know that Article 37 of the Federal Law of Public Health Care says that medical care in the territory of Russian Federation has to be based on clinical recommendations. Recently, the normative documentation has been approved, which introduces the step-by-step introduction of evidence-based decisions in clinical practice. And as of January 1st, 22nd, this decision is in force, and in the normative documentation stated here, we have all these stages. As we know, the basis of clinical recommendations is evidence-based medicine. Currently, the model of continuous medical education presented here Recently, the new regulation on accreditation of medical professional was adopted, and once in every 5 years, each physician should go through a continuous education course, which include the portfolio of continuous education, or cycles continuous education, or additional professional programs, 18 hours and above. And the second part is educational events and interactive educational modules. Our academy is actively involved in the development and implementation of both continuous education programs and running the events, running educational events. All they are using the portal of continuous medical education. It is important that these educational activities are based on one hand on professional standards. Therefore, they improve competence according to the functions of professional standards, and the main content are clinical recommendations, including clinical recommendations developed by professional community, approved by the Healthcare Practitioner Council of the Healthcare Ministry, and further used for development standards of treatment. And many of our professors are the developers of clinical recommendations as the board members of professional associations. Definitely they are using Cochrane evidence to on this or that medical intervention, including drugs. According to the normative document of the government of Russian Federation, once the COVID-19 pandemic came in the situation of absence of clinical recommendations, the healthcare should be based on temporary methodological recommendations. We all know this because based on the temporary methodological recommendations, which also should be evidence-based, and more of such knowledge is accumulated and is available. So based on this methodological recommendation, Roszdravnadzor, Russian Healthcare Vigilance Agency, and Ministry of Health developed checklists aimed at quality healthcare to COVID-19 patients. Once the pandemic started, and once we had a need to use certain drugs in treatment of COVID-19 patients, we found ourselves facing a crisis. Once we started treating the patients, forming initial protocols and recommendations on their treatment, these protocols have been based on something that I had a feeling that looking at that we are leaving evidence-based medicine, transfer to some type of medicine from the past century or even the 19th century, based on the hope that, drugs we used then, hydroxychloroquine, we believed that they will assist our patients with COVID-19. And there was uncertainty, especially initially. And a lot of fake news contributed to this uncertainty. They were generated by mass media, they were generated by some groups which are active till now, destructive groups, I would call them. And sometimes I've seen doctors in YouTube, they were holding a package of this or that medication, saying that it's a must to use in order to avoid the disease or to cure the disease. And definitely under that situation and in that conditions, doctors needed in evidence-based information. So the ground of our Academy of Continuous Medical Education was a key stakeholder here and the key player in this. So with this thought in mind, in our academy, with the approval of Healthcare Ministry, we have created the special center for information support on decision-making on the drug therapy of COVID-19. The backbone of this center are the professionals in clinical pharmacology and experts from other areas, depending on the demand. We have formulated a standard operation procedure of scientifically based decisions on this or that issues of therapy of COVID-19 obtained from the pharmacologist. You see this procedure here. The goal was to provide the physician with entire resource of information started from in silico resource and studies from in silico study and in silico research, continuing in vitro study from medical protocols available here and abroad, from the information about the registered protocols of this or that medication, clinical cases, description, and conclusion. And the leading role here has been played by Cochrane evidence and Cochrane systematic reviews. We do continue this activity till now. It is presented on a PharmaCovid website, which is at the portal of Russian Continuous Medical Education Academy. We are now working not in an emergency mode, we are working in planned mode, systematic mode, and we publish systematic reviews in Pharmateca magazine, which are very popular and on demand. That time, at the very beginning of pandemics, the work of this center allowed physicians and clinical pharmacologists to make clinical decisions, including the development of local protocols. Here you see how the conclusion on standard operation procedure has been generated and presented to physicians and clinical pharmacologists and published on the website. Altogether, we have processed more than 50 requests and more than 30,000 downloads and more than 100,000 contacts with our web page. We have summarized the work of the center using polls among physicians who are using it, and we see that this system of information support, evidence-based information support, is in demand by the doctors. And many doctors said that they wish this system to be enlarged and to work not only about COVID-19 but on a regular basis as an informational center. We have published an article based on the experience of the work of our center in British Clinical Pharmacology magazine, and editor-in-chief commented on our positive experience and said it should be translated to other countries, especially the countries which have a deficit of clinical pharmacologists, and this almost everywhere, including the Russian Federation. I have to say that temporary methodological recommendation, the information generated by PharmaCovid Center, and the information on systematic reviews and meta-analysis, including Cochrane's systematic reviews, is included in the study materials and programs estimating the healthcare quality to the patients with COVID-19. These materials are used in professional programs and also in educational events and interactive modules, not only for physicians, but for nurses and junior healthcare staff working in COVID hospitals. Our academy has developed over 40 programs on COVID-19, covering various aspects: general programs, oncologist program, endocrinology program with a special patient group, pharmacological aspects of using of drugs, usage of drugs by COVID-19 patients, and also related not only to physicians but to nurses as well. The characteristic feature of this program is not that they just exist, but the content is being changed. The content is being updated in real time when new evidence comes into life. recently we have included the results of Cochrane systematic review on monoclonal antibodies to S protein into the module of providing healthcare to COVID-19 patients. The functioning of the Center of Translation of Evidence-Based Knowledge, Cochrane Russia, cannot be underestimated. It's a very important step. Currently, we have developed a roadmap for the functioning of this center, hosted by the Russian Academy for Continuous Medical Education. And we have included the modules dedicated to systematic reviews, as part of interns program, as part of professional retraining, and we are planning to include the information on the latest Cochrane systematic reviews into educational events implemented together with the associations of medical association, together with the Russian Academy for Continuous Medical Education. Here we see the page for the Center of Translation of Evidence-Based Medical Knowledge, and we're grateful for the opportunity to use Cochrane Library. And the statistics said that Russian users are most frequent users of Cochrane Library, including for the needs of clinical decisions. Here you see Cochrane page, Cochrane Russia page, and the information that Russian doctors are actively using Cochrane, and our center plays a very important role here. Why Cochrane Russia is functioning on the basis of this academy? We think it's logical because Academy is the leading establishment of healthcare ministry in the area of continuous education. We are planning more educational programs compared to other educational establishments. We have 4,000 educational programs in all areas of medicine. We are implementing programs for nurses. More than 60,000 physicians are trained in all branches of our academy. Add 100,000 or 120,000 physicians trained for COVID-19 a year. All this is implemented in over 200 chairs of our academy. We have a large faculty, highly trained, highly knowledgeable, which includes most of them, or all of them, have PhD, including academicians, Russian Academy of Science members. We have leading specialists of the regions, leading specialists of healthcare ministry, presidents of professional societies. We are using simulators, and it is important that the Federal Accreditation Center was established in our academy with the task of support of accreditation, and this portfolio includes continuous education programs and educational events. We are running more than 200 educational events a year in this academy, and we are planning that in each of these events will include Cochrane evidence as a must procedure, as a mandatory procedure for the translation of knowledge into medical practice. This is our website where you can find the information on all our educational activities, including educational budget educational programs and out-of-budget educational programs. And I would like to conclude my speech with the statement of Boris Vodchal, who was the first one to open clinical pharmacology course in continuous education academy in 1962. He was the head of the chair that I'm the head of now, and he said we have to learn how to treat patients throughout our life. And this treatment should find reflection not only in educational plans, but should follow the doctor through all his professional life. Our programs are aimed at continuous education and aimed at the need of improving your competence throughout your professional life. Thank you for your attention.
Полноценно освещена возможность понимания той большой роли, которая имеет наша академия в образовании наших врачей нашей страны.
Thank you very much. Thank you for talking about this role that professional education has in the system of professional education of doctors here. And thank you very much about telling us. Thank you for telling us about the role of Cochrane evidence and its integration into the educational process. So the member of the Russian Academy of Sciences, Boris Vodchil, was really an authority on the subject. You gave us a quote from 1962, and look how relevant it is today. And when we're talking about our academy in Moscow, you should probably mention the number of journals that you publish, where editors-in-chief are renowned doctors and experts in the field. So right now, we also have Cochrane clubs. I am the editor-in-chief of the Modern Oncology Department, and we organize Cochrane clubs in our journal as well. So we're going to expand on this as well. So let's proceed, Dmitry. Thank you very much, Irina. Thank you for your kind words. Thank you for everything that you wished. Right now, I would like to give the floor to Lila Zyganshina, Professor, Director of Cochrane Russia, the leading coordinator for the Center of Translation of Evidence-Based Medical Knowledge in the Methodology Institute of the Academy for Professional Development. She will talk about 6 years of Cochrane in Russia, new start and future prospects. Thank you very much, Dmitry. Thank you very much, Irina. It is a great pleasure for me to talk at this seminal event. And I would like to say, Dmitry, Irina, Yelena, dear colleagues, today marks a celebration. Today we have a celebration in the Russian Academy of Continuous Medical Education. Today we have a celebration in Russia. This is the Cochrane celebration. So today we would like to announce that Cochrane Russia now has a new home, the Russian Academy of Continuous Medical Education. So in my talk today, I wanted to tell a little bit about our past and to give you some outlook on our future. As Dmitry mentioned, we do have a decree published on the 19th of January of the current year. We need to develop the Center for the Translation of Medical Knowledge. We got approval of our well-thought-of application, and so the agreement was signed on the 14th of January. We would like to welcome all of the delegates to this seminar. On the 2nd of December, we registered more than 2,252 delegates, and in the morning I was told that more than 2,500 delegates registered for this event. I do hope that the majority of you are here with us. So let's see what we started with. Our first conference was QICOM, was in 2015. It was attended by 165 delegates. We all traveled to Kazan. We celebrated 3 years of the symposium. In 2018, we had 110 delegates, and today we are celebrating 6 years of Cochrane in Russia. Now we have a new home of the Russian Academy of Continuous Medical Education. We have more than 160 towns of the Russian Federation. Other countries are also involved: Azerbaijan, Kazakhstan, Kyrgyzstan, USA, and Ukraine. Everybody is with us today. We would like to thank the organizers of the seminar, of this workshop. We would like to thank the Central Executive Committee of Cochrane, Cochrane Denmark, Cochrane Sweden, EVIPNet. We would like to thank the country office of WHO, and of course, we would like to thank the Wiley Publishing House. Thank you very much, dear colleagues. So let's reminisce a little bit about our history. Starting from the year 2000, we were developing clinical pharmacology that Dmitry told us about in his talk. Then we reached the year of 2015, when the Central Executive Committee of Cochrane decided to introduce Cochrane Russia as a North Cochrane Center. And let's go year by year. Let's look at the pictures. So here you see the first Cochrane workshop that was held in Russia. It was a workshop on systematic review. You see Karsten, you see Lorenz Moe from the WHO, you see Mark Wilson, you see Dr. Hans Hagerseil, and he was the initiator of our work on quality or sustainable use of medicines. And back at that conference, we were lucky enough to publish all of the works of the delegates in the Cochrane Journal. In 2016, we had many events organized by Cochrane Russia, and we had a workshop as well. In 2017, we started collaborating with some medical journals, and we are extremely happy that the journal published by the Russian Academy of Continuous Medical Education, which is the leading publication on state-of-the-art medical education and modern pharmacology. We are very happy that now we collaborate with these journals. Now, the year is 2018. Here is the year 2019. You see our further development. We organized a workshop in Moscow to evaluate technologies in healthcare. We have guests and delegates from Norway. We have representatives from the Great Group and representatives from Cochrane and Norway. Now, the year 2020, the start of the pandemic, and it was the last in-person or face-to-face workshop in London. Then we had online workshops, and you see a great response to the pandemic that we got from Cochrane. And we were very proud that in 2020 we organized our first online webinar. You see our faces, you see our banner. And so that finishes with the history, and now we arrive of this day to this day when Cochrane got a new home in Russia. Now we are housed in the Russian Academy of Professional Medical Education. We have a developed roadmap. That means that we include the results of Cochrane systematic reviews in all systematic materials of professional medical education provided by the Russian Academy of Continuous Medical Education. Here you see all of our workshops summarized. You see the webinar we had in 2020, and today's webinar continues this list. Dear delegates, when you registered for this seminar, we asked you to answer a couple of questions, and these were the same questions that we asked back in 2015. So let me go briefly through the results of this poll. We asked the delegates whether they participated in Cochrane activities. So you see, right now we have a much broader audience, and the audience is also broader when it comes to people who want to participate in Cochrane activities. So what kind of participation in Cochrane would you choose? A lot of you choose actively. Some of you are considering many options, and I think that today's webinar will also inform you about the options for contribution. And the last question was, do you use Cochrane systematic reviews in your work? Yes, the majority of you answered yes. And it's great to know. We also asked about the achievements and the developments of evidence-based medicine. And what is extremely wonderful to find out is that your responses were very similar. Then we asked you about the hurdles, because when we know the hurdles, we can overcome them and continue the development. And of course, people talked about the language barrier or unavailability of Cochrane Library or the absence of free access. We are working to resolve this issue, and we do hope that next year we will have a national subscription. The Academy is working really hard to achieve that. And here you see some quotes from your responses. So you want to preserve Cochrane Russia. You want to introduce evidence-based medicine course at St. Petersburg Medical University. You also said that there are some barriers. Some people said that there are no barriers, but some people noted that there is no way to specialize and exchange experience with other cities in Russian Federation and other countries. So the Academy does everything to expand the possibility for collaboration with other countries. We asked you about overcoming the barriers, and of course, to overcome the barriers, we need to have educational events. We need to introduce evidence-based medicine at all levels of healthcare. That's what Margaret was talking about. We need to use evidence at all levels of healthcare. You need to have access to Cochrane Library, and of course, clinical guidelines should also include Cochrane evidence. Do you use Cochrane data in clinical work? Yes, you do, but we, of course, want 100% of you to use it. So we asked people, why don't they use Cochrane evidence in their work? People said that they don't have much time, or they have never heard about Cochrane reviews or Cochrane libraries. So we will aim to educate you about this, and we will talk more about this during the second half of our seminar. So we asked young doctors and young researchers of the Academy. And here you see the results of this survey. This survey was about whether young doctors know about Cochrane or evidence-based medicine. And of course, we still have young doctors who haven't heard about it. And those doctors who answered that they know about Cochrane, here we asked the participants what people view as evidence-based medicine. Some people said that it is just statistical information. Some people acknowledge that they don't know about evidence-based medicine. Therefore, here we have a lot to work on in the future and to include it into our roadmap. To conclude, I would like to talk about the foundational work on evidence-based medicine by David Sackett, who is one of the fathers of the evidence-based medicine. In the British Medical Journal, he talked about evidence-based evidence in 1996, and he said it's very important to know what evidence-based medicine is and what it is. So it is not a cookbook. It is not an old hat. Evidence-based medicine is something that can be practiced, and I do hope that today's webinar will show you what evidence-based medicine is. So please stay updated on our events. We will definitely introduce more clarity. And of course, we need to use best clinical practice. We need to use best clinical research, and that is something that we are working on in the Russian Academy of Continuous Medical Education. And at the turn of this century, there was an article published in Lancet that said that Cochrane Library rivals Human Genome Project. So the value of Cochrane evidence has been confirmed for the global healthcare. And that is why WHO uses Cochrane evidence in its practice. And I would like to show you a slide talking about educational modules so that Dmitry covered in his talk. So here you see evidence-based medicine and what it is. So you see these three circles and how they intersect in the middle. So you see things that are based on the best medicine, but it should be combined with clinical judgment of an individual doctor, of professional community. It should include values and preferences of the patient. So this is what makes evidence-based medicine. And right now, you can find the definition of it in encyclopedias. So we asked you whether you want to have satellites of Cochrane Russia in your region or in your city. And the majority of you answered yes. We're very happy to hear that. And we hope that we will continue to work productively and we continue to contribute a lot to the development of healthcare in this country. Thank you very much for your attention. Thank you very much, Lilia. And Lilia is not just a curator of Cochrane Russia. She is also very enthusiastic about the development of Cochrane in Russia. She truly understands the value of her work, and that is why she managed to achieve such a huge success in a very short period, in the 6 years of Cochrane in Russia. So we see that Cochrane Russia already shows how varied the activities of Cochrane Russia are. And of course, I would like to underline one more time that because of the efforts of Cochrane Russia, analytical reviews are becoming more available and they are in high demand. So we always turn to Cochrane reviews. We use them in our everyday work. And I think that we are #1 when it comes to the use of Cochrane information in Russia. And it is great that our medical community understands the importance of evidence. So now we need to enable our doctors so that they can use Cochrane evidence, so they can understand it and use it for the benefit of their patients and for the benefit of the healthcare system overall. So this concludes the first part of our webinar. And now we're going to have a very interesting format. This is the first time we are using this format in Russia. And this format will be group discussion of certain issues. So I would like to give you the floor, Lilia, so you can explain all of the housekeeping to the colleagues. And then we'll return back here in 20 minutes. Thank you very much, Irina. Dear colleagues, we really worked hard to organize this. We acted upon our recommendation and with the support of Dmitry and the entire academy. So we did everything in our power to organize this virtual meeting according to Cochrane traditions. And you probably know that Cochrane traditions truly value discussions. We are a professional community, and so we do everything to expand our community, to expand the use of evidence. Therefore, our discussions are vital. So right now, I will read the protocol that we developed with our organizers, and I would like to thank our organizers. I would like to thank Alessia and all the people who supported us. Thank you very much for your tremendous efforts. So, what are we going to do now? Please listen attentively. It will only take a few minutes. If something doesn't work, then we will address this issue. Right now, you are using the translation website, and in order to move to the breakout room, you need to click on the link that is posted in the webinar chat. I hope that the link is already there. So it will be to the right from the player window. It is a chat. We received a lot of questions from dear colleagues. Thank you very much. And we will discuss your questions when we have the Q&A session. And right now, we're going to have group discussions so that you can participate in these discussions, so you can express your points of view, so you can ask the questions about everything that we talked about in the first part of this event. Do we have the link, Alessia? Not yet. So now we are waiting for the link on the chat. And while we're waiting for this, let me read some acknowledgements and some thanks from you. So in the chat, I see that you're saying thank you very much for the interesting talks. I hope that our work will be productive. I would like to wish everyone good luck. Oh, by the way, the link is posted to the chat. Well, we got a lot of acknowledgements, but also some questions. So the link is on the chat, and this is the link to the breakout rooms in Zoom. So please click on the link. Please click on the link that you see in the chat. I'll also try to join a breakout room. All right, thank you very much, Alessia. I see that the majority of you clicked on the link, but a lot of you are still in the general room. So in the next 1 or 2 minutes, you will see a pop-up window on your screen. So in this window, you'll see an invitation to join a breakout room number such and such. So in the breakout rooms, basically, you are going to have a pop-up window which will invite you to join a breakout room. So please click on the pop-up window. And once you click on the pop-up window, you will be able to join a breakout room. Which breakout room you will end up in? Well, here we used Cochrane principles, and you know that the gold standard of Cochrane is randomized clinical trials, controlled clinical trials. Therefore, you will be assigned to a group very randomly, so the system will randomize you to a group, and you will be divided into groups. So we're going to have 3 groups.
Мы попросим всех модераторов групп.
We'll be offered a question. We'll ask group moderators to send you slides beforehand. We ask them to share the screen with the question with all the participants to discuss the question, and if possible, to accumulate all the suggestions as a result of this group discussion, and to present these results to the moderators. That will, the general discussion that will take place in 20 minutes. Did you succeed? Did everyone, Alessia? If you have any issues, please write in the chat. We are still waiting. In the meantime, let me read messages from the chat. The presentations are highly informative. Thank you very much. Thank you very much. Did you get the link? I believe you are using this link to proceed. So go use the link, and then you will be divided into groups, and later and we'll see you in Zoom groups now.
В группах Zoom. Так. У нас на экране здесь выведен общий зал или здесь будет какая-то группа, Олеся?
What do we have at this screen? The hall or a group?
Да.
Yeah.
То есть группа, где модераторами будут Дмитрий Алексеевич, я и Марга, она будет.
So group moderated by Dmitry, me and Margot will be here.
Уже с вами в нашей общей виртуальной аудитории. И сейчас уже будет доступен синхронный перевод. Я буду говорить по-русски, а для наших иностранных коллег будет обеспечен синхронный перевод. Для этого мы с вами перешли в общий виртуальный зал, И пока еще коллеги чуть-чуть подсоединяются, я прочитаю для тех, кто уже есть, еще пришедшие несколько ваших сообщений из чата. Очень большая благодарность организаторам. Это лучшая конференция, на которой я был. От кого вот это я не поняла, от Ольги Николаевны я зачитала. Вот, Дмитрий Алексеевич, вопросы все к вам зачитала и благодарности зачитала. Так, у нас были вопросы к Карстену. Карстен, are you here already? Карстен? Is Карстен here? Он был? Карстен, are you here? Диляра? Диляра, вы здесь? Диляра? Dina здесь. Dina, Margaret, are you here? There were very special thanks to Dina, especially for your presentation on the implementation. Dear Margaret, there were special thanks to you. I was reading these messages from chat when we were moving to the Zoom. Oh, here is Karsten. Дорогие коллеги, были вопросы к Карстену. Я зачитаю по-русски, я надеюсь, что перевод идет к Карстену на английском языке. Уважаемый Карстен, спасибо за устную презентацию. Есть ли систематические обзоры по вакцинации в области ковид? Очень важно убедить людей вакцинироваться, для этого нужны систематические данные. Перевод идет, Олесь? Ага. Угу. Karsten, there is another question to you, which was in English. Dear Karsten, thanks for your oral presentation. Oh, this is the same question which I just read in Russian. What about systematic reviews for COVID vaccination? In our country, it is a very complicated question, and we need systematic data to convince people.
Yeah, I think that is actually a very good example of our need to meet current demands for evidence. So traditionally, our systematic reviews has been done very much retrospectively. So we have looked at what has been published, often with a very long time horizon. But we need to move in the direction of doing what's called living systematic reviews, so that we continuously update the available evidence, and preferably in a way where we do not have to wait for publication of data, but where we can get access directly to data submitted to drug regulatory authorities, so that we can use that to present the reviews that are needed as soon as possible. Because obviously a case like COVID-19 vaccines, you can't wait a year or 2 years for a Cochrane review. As it's traditionally done, you need to have the evidence available much quicker than that. So, and that is something we've tried to do with the COVID-19 response, where we've done rapid reviews and tried to collect forces within Cochrane to get these reviews done as quickly as at all possible to meet those immediate demands for evidence.
Спасибо большое. Thank you very much, Karsten. There are more questions.
Thank you very much, Karsten.
But it seems to me since we all are... Да, спасибо большое. Я прошу прощения, я неожиданно...
Sorry.
Я буду говорить по-русски.
I will speak in Russian.
Да, мы сейчас обсудим результаты...
We'll now discuss the results of the group discussion. And with your permission, let me start with Karsten. The remaining questions to Karsten will be asked at the end of discussion. Karsten and Dilyara, please present the results of your group discussion.
I'm a bit uncertain whether it's me or Dilyara who is going to summarize, or I don't know if it's an advantage that it's in Russian, or if I should try to.
We would be happy either way.
Okay. Well, yeah, I can try to summarize some of what we discussed. So, so the overall question for our group was how to make Cochrane evidence more usable in Russia, and how to get Cochrane evidence implemented into practice in a Russian setting. And we had some excellent questions from group members along the way. So some of the things that we discussed were how to make sure that Cochrane evidence is used by governmental authorities to set practice standards and policies nationally. And we were talking about how an increasing number of countries have adopted the grade system. My country is one example, but also how this change in the direction of making guidelines in a more evidence-based and structured manner has been a long struggle. We've had a Cochrane Center in my own country for 20 years before our national health authority started to use the grade system to make guidelines. So it's a long struggle. It takes time to change these things, but it's really important. We also talked about, so Cochrane evidence can be used at one level, which is for guideline and policy setting, but it can also be used at the local setting by the individual clinician. From Cochrane centrally, we've been able to see a sharp increase in the use of Cochrane evidence in terms of accessing individual reviews in the library since Lilia and her group have started translating summary of findings tables and abstracts of Cochrane reviews, because clearly the language issue is very important in many settings, and the Cochrane Library content is being translated into several languages, and that is really a key to making the evidence accessible and usable in clinical practice. So that is certainly an important element and function of Cochrane Russia. We also discussed training of physicians. So part of the education at medical schools should be focusing on teaching students the fundamental premises of evidence-based practice. How do you evaluate the quality and reliability of evidence? Where do you go and search for the most reliable sources of evidence to inform your practice? And that is like changing government policy setting. It's also a long practice, at least in my country. Changing how the curriculum of medical students is put together is difficult. Our universities can be quite conservative in terms of making changes. So that's also a long process. Some universities in Denmark, in my country, started to do these courses. But for instance, our main university, the University of Copenhagen, do not have a course for medical students specifically to develop students' skills in evidence-based medicine and practice. So that is also an area where it's important to focus your research sources, because no matter what medical specialty you're going to practice eventually, it will be a really important tool for you to be able to assess the medical literature and knowing where to go for the most important or the most reliable evidence. Does that summarize things a bit, Dilara, or do you have something to add?
Karsten, unfortunately, Dilara is not yet here, so I think we're the most comprehensive, and if anything, we hope that Dilara will have a chance to add in the second half of the workshop. Yeah, and thank you very much. We will now move to group 2. And we will ask Margaret to sum up our discussion.
Yes.
Подвести итог.
We did have a bit of interpretation issues, so I tried my best to summarize, but then feel free to add and all the missing information that that I may not have captured from my very basic Russian skills. So the question that was posed for our discussion group was that how we can apply WHO concept for evidence to policy in health in Russian healthcare. What are the plans, achievements, and barriers? We had a great opportunity to hear from one of the participants who was from Kazakhstan and had first-hand experience in participating in EVIPNet in Kazakhstan, and she shared their experience as well as barriers in terms of what are what they are facing in Kazakhstan in terms of having a better evidence-informed decision-making. I also know that the Kazakhstan group led by Vitaly Koykov, also mentioned by the speaker, is developing the situation analysis of evidence-informed policymaking in Kazakhstan, which is now in the final stages. It will be available both in Russian as well as English for everyone who is interested to learn the Kazakhstan case in terms of having understanding of what are the barriers, because the barriers are quite universal, what we have seen also from the systematic reviews I shared, but also across the different systematic, the situation analyses we have done in countries, that there is a large degree of agreement in terms of those barriers. But also the country has identified what are the opportunities, because these barriers can be turned into opportunities, because we cannot just simply accept those barriers, but rather to find ways, collaborations, raising awareness, as well as applying universal tools to address those issues systematically. And I know that in addition to barriers, Kazakhstan has already made progress in applying some of these opportunities and establishing more stronger evidence-informed policymaking. So this is something that can be used as a lessons learned. And this is one value of the network, is that it is really sharing our common struggles and challenges, and also how innovations and ways to overcome them with our member countries, and this only strengthens the common approaches and finding the solutions. We don't have to make mistakes ourselves, but also learning these good examples, and also being motivated and inspired by other countries. So I come from Estonia, where I joined, before I joined EVIPNet Europe, we were very much inspired by the progress of Slovenia and Hungary in their efforts of evidence-informed policy making in terms of doing the situation analysis and evidence-free policy. And I remember how motivated our team of experts who developed the first evidence-free policy on sugar-sweetened beverages to inform policy decisions, that how motivated they were that they would be the first one to publish it and beat the Hungarian team. I mean, the competition, it's not a right word, but it is really motivation and inspiration to be better in establishing the systems and mechanisms and evidence-informed policymaking. So Lilia, please fill in the gaps for my translation. Thank you.
Thank you very much, Marga. I think all beautifully, and I think we were lucky with our random allocation of participants. We have participants from Kazakhstan to show Russia the example of moving forward to EVIPNet projects. So I think it worked out perfectly. And thank you very much for all the insights. And on behalf of the leadership of the Academy, we do hope that we are looking forward to close collaboration. Thank you very much. Thank you very much. Спасибо большое. Дорогие коллеги, мы продолжаем, и мы стараемся ускоряться.
Dear colleagues, we continue. We try to speed up because we have 5 minutes till the beginning of our next session. Our next speakers are already waiting online, therefore we'll not have a break. Sorry for that. We made a decision by the organizers not to have a break. Now it's group 3, and we'll ask Dina to briefly summarize the results of this meeting. I have already the opinion that the discussions were active, productive in the first group, and in the second group, just Margaret said. Dina, the floor is yours.
Thank you, Lilia. We also had a very productive discussion in our group, and thank you very much for Natalia from Wiley for stepping in and helping translate, because we experienced a few technical problems there, but nothing that we couldn't fix. So an overall theme that I gathered from this discussion that I had in my group was a need from clinicians for tools and knowledge to help them in their practice address medical excess, overdiagnosis and overtreatment, especially in a COVID context. So I really recognized their need and addressed that the establishment of this field was very much with the intention to help them, and even more so now during a COVID pandemic. We talked about some of the projects that I highlighted in my presentation that are in the pipeline to help them. Some are long-term, such as establishing a grade working group to address medical excess. And some are rather short-term, such as the establishment of a special collection of Cochrane reviews focusing on de-implementation. I was able to share with them a link, thanks to you, Lilia, and your team for translating that special collection into Russian. And I again highlighted that this is going to be, and hopefully will be soon, a go-to platform for people. Now, I do recognize that there is only a handful of reviews here, but it is a beginning to create a knowledge base for people and addressing the issues highlighted in our group. So yes, and I would just like to again readdress that if you have any follow-up questions with the discussions that we have, then please by all means email me, because we got caught up in time, and I think there was some questions there that weren't addressed sufficiently. So thank you again, Lilia, for giving us the opportunity to discuss this in a group.
Thank you very much, Dina. Yes, it sounds like it was a very fruitful discussion and very much needed, and particularly here. And our rector, Professor Dmitry Sychov, is the lead of the prescribing project here in Russia as the leading clinical pharmacologist. So I hope very much that we will be able to establish close contacts and work together for the implementation on the basis of solid Cochrane evidence.
Yes, that would be.
Thank you very much, Dina.
Thank you.
And we have a few questions to Karsten, but we do not have, unfortunately, now time for the questions. If you do not mind, Karsten, I will just now announce the questions in Russian. And if you will be able to give your answers in the chat, if you do not stay till the end, till the second discussion, or if you stay, you will have a chance to give those answers. All right. So the questions are, I'm turning into Russian. Не могли бы дать определение scoping review?
Could you please define scoping review definition? Next question to Karsten. How, when making reviews, you overcome the prejudice factor, the shift factors, including certain interested parties, including the factors of certain interested parties. So how do you overcome the prejudice factor or researchers being engaged or interested? And the third question for Karsten. What are the results of Cochrane review on ash using in hand wash? These are the three questions, dear colleagues. Right now.
So we will be looking forward to your answers, Karsten.
Мы ждем.
We need guidance from our technical organizers. Now we move without a break, Alessia, we move without a break into the second part of the workshop. Да, дорогие коллеги, мы переходим с вами.
Dear colleague, we move to the general conference, and we proceed to the second part of our conference. Dmitry?
Уважаемые коллеги, мы с вами...
Dear colleagues, we are going to proceed with our program. This is going to be the second part of our intensive seminar on Cochrane-based evidence or on Cochrane evidence. So I would like to give the floor to Richard Morley from the Central Executive Committee of Cochrane from York, the United Kingdom. So he will talk to us about online training, collaborative development, Cochrane evidence. Over to you, Richard.
Richard, are you ready?
Yes, hello. I am ready. Yes, thank you.
Thank you.
Shall I begin?
Yes.
Thank you. I'll just share my screen. tell me, can you see my slides?
Yeah.
Thank you. Well, hello, everyone. I'm delighted to be here, to be invited to speak to you this morning. And I'm just going to turn off my camera now. I'm delighted to be with you this morning. And thank you so much for inviting me to speak to you, all the way from York in the United Kingdom. It's a real pleasure to be able to join you, and especially to have the chance to celebrate your launch of Evidence Essentials, the learning modules that we've produced in Russian. So that's a great pleasure to me to see this. I'm very excited. So I'm Richard Morley. I'm Cochrane's Consumer Engagement Officer and part of Cochrane's central team. And I'm sorry that I can't present to you in Russian. However, colleagues in the Russian Cochrane Center have very kindly translated my slides, and I do hope that you'll be able to follow my presentation. So this morning, I'm going to be speaking to you for about 20 minutes in total. I'm going to talk to you a little bit about Cochrane's training and its work with healthcare consumers, and then describe to you the origins of Evidence Essentials, briefly describe what's in the learning modules, which cover broadly evidence-based medicine, shared decision-making, and co-production, with the healthcare consumer in mind, but not exclusively. These modules are very useful also for healthcare professionals, learning for healthcare professionals too. I'm going to finish with some ideas about how perhaps you might also want to be involved in Cochrane if you're not already. So a little bit about my work. It's my privilege to work with the public about science, about health evidence and Cochrane evidence in particular. Patients, carers and the public, what Cochrane calls consumers, are decision makers, often facing uncertainty about the choices they have to make when it comes to their healthcare. And so part of our work with consumers is to create an environment where people can understand evidence, ask for it, and can use it in discussions with healthcare professionals. So a part of my work involves building a global health community of volunteers, and the Cochrane Consumer Network is made up of nearly 2,000 people across the globe in 79 countries. And they're interested in evidence, advocate for it, and also help to produce it, because co-production of Cochrane evidence is an important principle, and members of the network are involved as part of author teams, as peer reviewers, and also in helping to govern the organization, govern Cochrane. I also work closely with the Cochrane training team, and Cochrane, as you perhaps know, produces a large range of learning. It supports individuals who are interested in producing Cochrane evidence and being part of sharing Cochrane evidence. And on the website, which you can see the address there, there's a wide range of resources. Many of the resources are free to access for the public. Some is behind a paywall, but if you're a member of Cochrane and a Cochrane team, an author team, for example, you can access these resources for free. And there's also a learning live program, which is online webinars for you as well. So I'm going to talk now about Evidence Essentials. Why did we produce the learning, Evidence Essentials learning? Well, Cochrane is a globally important producer of trusted evidence, and there are over 7,500 Cochrane systematic reviews in the Cochrane Library. And so our evidence exists so that people can make better decisions about their healthcare. Cochrane's audience is very wide. It includes healthcare professionals, policymakers, journalists, and the group that I'm particularly concerned about, patients, carers, and the public. So the question is, how can the public understand and use Cochrane's complex evidence? If you look for learning online, you can find information as a member of the public, but much of it is aimed at healthcare professionals or medical students, for example. And much of this is quite complex. It's written in ways that people, even some healthcare professionals, find difficult to understand. And we wanted to produce something for ordinary people in a language that they also could understand. And interestingly, what we hadn't expected when we started to produce this Evidence Essentials was the coronavirus pandemic and the large amount of information that people are having to come to terms with and to make decisions about. And some of that information comes along with disinformation as well. Some of that information deliberately incorrect. How can people understand what's true and what isn't true online? And so these resources have turned out to be doubly useful. The other thing is, of course, we wanted to give people who co-produce our evidence a place to start if they're going to sit as alongside professional researchers and healthcare professionals and be involved in that learning, in that evidence production. So how did we approach this? The key principles was that we wanted to co-produce our resource. We wanted to create it with consumers because they were the ones that we hoped would use it. It was important that we got it right. So first of all, we worked with consumers in informal meetings to think about the kind of information that consumers might want. We formed a project group of patients and carers, researchers, and other people with an interest in learning. And we developed what we called a learning and skills framework, which identified all the topics, content, and levels of understanding that we wanted to cover in our future learning. Next, I and a healthcare consumer wrote together the raw content for this learning, and then worked with our learning team and an online learning specialist, Kiln, to build what we hoped would be an attractive, interactive, friendly, accessible learning. And we tested this with our users and launched it in 2019. Since then, over 36,000 people have taken this learning, which we're very excited about. It's been translated into German and, to my great pleasure, into Russian. And I want to thank all the people in the Cochrane Russia team who've been part of translating this resource from English into Russian. I can't tell you how excited I am about that. I want to thank Ekaterina especially. I'll briefly describe what's in the learning. There are 4 modules. The journey through the learning is led by a fictional consumer called Eleni, and her story is one of discovering evidence-based medicine and clinical trials, systematic reviews, and how to use them. We did that because we thought that would be a friendly way and an accessible way to make our learning come to life. The first module is an introduction to evidence-based medicine. So what it is, why it matters, and how it's part of a process of continual improvement. The second module is an introduction to randomized controlled trials. So here we cover clinical trials and randomized controlled trials. We look at what makes a good trial and think about all the things, the details, the complexity that goes into those trials. And if you're looking at a clinical trial critically, what you need to consider. In module 3, we look at systematic reviews. So here we describe what a systematic review is, what you can and perhaps can't get from a systematic review, and how their systematic reviews are produced and what they consist of. So things like the protocol and the full review and the way that systematic reviews are structured. And then in the 4th module, we introduce people to Cochrane reviews specifically, show people the Cochrane Library and how to find evidence that they might be looking for, how to understand the results of a Cochrane review. So particularly the things that healthcare consumers might be interested in, for example, the plain language summaries, the summary of findings tables, and forest plots, for example. And then in the 3rd part, we talk about shared decision making. So how patients and carers might use Cochrane evidence and other evidence to make informed healthcare decisions with people's healthcare practitioners. And also we link to a lot of resources so that people can find more information about their healthcare condition or get support. And that information is globally relevant. So those are the 4 modules that have been translated into Russian. I'm very pleased to say that next week we'll be launching a 5th module and our final in this series. And this one is about consumer involvement in Cochrane, because as I mentioned earlier, not only were our healthcare consumers users of Cochrane evidence, but they also help to produce it. So this final module describes how people can be involved, and it includes things like a welcome to Cochrane, why contribute to evidence as a member of the public, how to find your way around Cochrane, because Cochrane is a large and complicated organization, and then the different ways in which members of the public, healthcare consumers, can contribute to Cochrane, things like Cochrane Crowd and Task Exchange, to be involved in setting priorities for future research, choosing important outcomes, being part of author teams, peer review, and in other ways too. That's being launched next week in English. So I'll just very quickly finish now with, if you're interested in being a part of Cochrane, if you're not already, there are many ways in which you can be involved and contribute and just find out about what Cochrane does. For a start, you can join Cochrane. You can join as a member. Anyone is able to join. The first tier of membership is as a supporter. And that's a way to begin your journey. You can find out about Cochrane and what it does. As you get involved in Cochrane and perhaps start to contribute, you can win membership points until you become a full Cochrane member, which gives you the right, for example, to vote in elections. You can sign up for the latest information from Cochrane. There are a range of different email newsletters, and you can sign up for things that are important to you. And you can also join Cochrane Crowd and Task Exchange, and these are ways of getting involved.
Вы меня не пускаете. Да, лучше да.
Hello? So you can find out more by going to cochrane.org and following the links there to get involved. So I'd like to finish there and say thank you very much. There's my email address, rmorley@cochrane.org, or you can write to consumers@cochrane.org if you have any questions. Thank you so much.
Большое спасибо, дорогой Ричард.
Thank you very much, Richard. I think that was a much needed talk, and I do hope that we will have an opportunity to discuss all of the issues in more detail when we work in a group setting. I hope we'll have a chance to talk a lot more about consumers, about involving healthcare professionals, young doctors, and I hope we'll discuss how to make sure that the maximum amount of people join in and contribute to Cochrane. Thank you very much, Richard. We are getting a lot of questions from the audience, but we will answer these questions during the Q&A session. But I do have one question, and I think you can respond to it quickly. How can we go through the learning modules? Is it subscription only?
Richard,
do you hear me? How can a person join the learning modules? Are they subscription only? Hello, Richard? Hello, Richard? Can you hear us? Hello, Richard? Dear colleagues, while we're waiting for the translation of the question for Richard, I'm reading a lot of thanks that people are saying to Richard. Thank you very much, Richard, for giving us such useful information.
Dear Richard, can you hear us? Can you answer the question?
Yes.
Yeah,
are the learning modules
one question?
Yes. Are they for subscription only? They are absolutely free. They are free for everyone. All you need is a Cochrane account, which takes just 10 seconds to sign up for. You only need to submit your email address, and from then you are absolutely free. Anyone is free to subscribe to those modules and use them. Absolutely, they're free. Yes.
Большое спасибо, Ричард. Большое спасибо.
Thank you very much, Richard. So we are looking forward to our discussion. Now, dear colleagues, we're going to proceed with our program. And I would like to give the floor to our dear friend, Matteo Bruschettini, a dear friend who's been supporting Cochrane Russia for a long time. He's a director of Cochrane Sweden, located at the Skåne Hospital from Lund, Sweden. Matteo Bruschettini will talk to us about methodological expectations from Cochrane MESIR standards. MESIR standards in Russian.
Matteo, the floor is yours.
Thank you very much for inviting me to join this very relevant international workshop. Thank you very much to all organizers, and especially to Professor Lilia Ziganshina, Director of Cochrane Russia. We are collaborating together for a few years, and Cochrane Russia is inspiring actually many of us, Europe and outside Europe, looking at what we've been doing in terms of education, training, production of reviews, and dissemination. Thank you very much. Спасибо большое, Lilia. And thank you also for inviting me to speak about this topic, about methodological expectations of Cochrane intervention reviews. And congratulations again for Russia to be one of the 3 countries to succeed to translate these methodological standards into Russian. So together with the Japanese and the Spanish version. I know this is a huge effort, but is highly needed and appreciated, which can lead to higher quality in, first of all, conducting systematic reviews, but also in understanding systematic reviews and their methodology. These MESIR standards, where the C stands for Methodological Expectation of Cochrane Intervention Reviews, are completely integrated in all the flow of the production and revision of systematic reviews, of Cochrane reviews. So here I mentioned this slide, for example. So when we use the Cochrane software, which is called Review Manager, RevMan, we have within RevMan, we have that direct link to the MESIR standard. The same in the Cochrane Learning, we heard a few minutes ago. And but also, for example, my role as the editor at Cochrane Neonatal, also when we work as editors, so to review the systematic review, we use this checklist to review the protocols and the reviews of Cochrane reviews. And then, of course, the Cochrane Handbook, which was recently updated. So here a screenshot from one of my ongoing Cochrane reviews. And this is what was mentioned before, that on the right side, when you're working to write a Cochrane review in a RevMan, you have context, and then you have the MESIR standard with the exact link to which section of the MESIR standards is useful to look at to write that part of the review. And this is about the Cochrane Interactive Learning modules, which are available also in Russia. And again, on the right side, there are resources with, of course, links to the handbook, but also to the MESIR standards. So also for the learner, also for those with the limited experience in preparing systematic reviews, when assessing the cognitive learning, you can see what the MESIR standards say. This is it's taken from this link. Probably this takes to the English section, but it's possible to go to the Russian section, of course. And this will show that everything is mapped and updated. So the history when updates are ongoing, or the latest updates when and be conducted, what the main changes were, and then useful links to the PDF and to other sections. For example, see on the right, this C52 about assessing scope bias, an update of the standard is pending. It is very useful because we know that we are alert that guidance might change soon. And also here, an update is pending. Then in this slide, I would like to show that the methodological is available again also at this website. This is the latest version, beginning of this year. And you can access, for example, as a PDF, 127 pages, or in my opinion, more useful is the online version where you can directly click and go to the specific section that you need. Because there are, as you can see here, the 4 main sections in the MESIR standards, and 1, 2, 3, 4 with different letters. So my intention now in the last minute of the presentation is to show an example for each of these 4 sections. So for example, in total. So C, which it stands, the first section is about setting the research question. The second one, standard for the conduct of a new Cochrane review. The second one is for reporting here with PR, so reporting. The third one, which is for reporting new Cochrane intervention, and then the last one, the fourth one, is for the updates, so with the EU. So let's start with the first one. And there are 75 items. In the first subsection, there are, for example, this example, about developing the protocol of the review, C1 to C23. And the other further subsections to have further guidance. So setting the research question, the eligibility criteria, planning the review methods. Let's take this example. This is a Cochrane review on COVID-19. We published the protocol in September, and we now completed this Cochrane review, and so it's submitted. So I took this example because it's very important to define, to predefine a strategy for study with a subset of eligible participants. What does it mean? For example, you can see from the title that they were working at workers, but outside of healthcare settings. So you need to define already in the protocol that, for example, nurses, physiotherapists, medical doctors, and any workers in the hospital, for example, are not included in this review. And the same for example, what to do if you have a study reporting defects in both children, adolescents, and adults. So you need to specify in the protocol if you include any age, if you include from 18 or from which age. Here we're speaking about workers, so we don't expect to find infants or very young children, but of course in some countries you might find studies of people below 18 working. So it's important to specify this if they're included, and what to do if you find a study that might match inclusion criteria and includes population, for example, because of the age. Part of that might be included and part should not. So this should be specified. And this item, the C6, you can see here at the top of the Messier, provides guidance on how to do this. I take now another section, and it's again from the first one, the C, but that's the second part of the C. So it's about performing the review. And we have these subsections. We can quickly have a look, and then I will go to the next example. So this is a review that we just completed. It was commissioned by the World Health Organization, and it's about small babies, and it's about giving caffeine. Caffeine, together with antibiotics, is the most frequently used drug in preterm infants. So in this array, for example, it's about comparing high dose versus low dose. We know that caffeine works. So here the focus is comparing high versus low dose. And we're looking at the Messier standard, C39. How to deal with such a study. And what do we mean with the high and low dose? This should be defined in the protocol before looking at the results, to define what is high, what is low. And also, so which means, for example, to provide a threshold, I don't know, below, more than 20 milligram is high, below 20 is low. But it might be more complicated than that. It might be that there are some studies with extremely low dose, which we think that is almost like a placebo. So there might be also more thresholds to be defined in the protocol. I now go to this one, which is about the protocol reporting. And as again, you can see a long list for each section. And this is of course, it's not a pleasant reading to read all the Messier from the very beginning to the end, more than 100 pages, but it becomes very useful when we need to write a systematic review. So here, the list of the items. I want to take one more example. It's again about babies, and the drug is opioids. So we're looking now at PR 31, and as you can read here, studies with more than 2 groups, because when we do the comparison analysis to create a forest plot meta-analysis, we compare one intervention versus another in this analysis. So it's this type of direct comparison. But what to do if you find, when doing your own Cochrane review, you find a study where there are 3 groups? For example, in this case about opioids, it might be one type of opioid, another type of opioid, let's say morphine and fentanyl, and they are placebo. How to deal with that? These also should be specified in the protocol and should be correctly assessed in the results. This was published months ago, and it was translated in 10 different languages, and including the Russian, also with the Russian podcast is available for this review. So here the focus is from Messier, the guidance, what to do if you have more than 2 groups. And here, about my Russian is not very good, so I need to refresh my notes here. So we are speaking about reporting of a review conduct. So we are in the R for the reporting, and here you can see the details. So Messier is explaining also how to write in the manuscript in the Cochrane review, about title and authors, how to write in the abstract. So for each section, you have a useful guidance. And I choose this example here for the background. So this is a review we published last year, December, and we're now waiting for the application of the update. Here the focus are 19, so it's about the background. In this case, the topic is quite specialistic, not very intuitive for citizens. And so it's about this device to monitor sugar levels, again, in babies. So in the background, it's important to provide the background, so which is already in the protocol, and then also in the full review, to provide a clear description. And sometimes it's also useful to add, for example, a figure or a graph to display what this device is doing and how it can interact with the body. And this is finally my last example. Let's see. Yes, it's about the R60, which is about integrating the findings. And sorry, I think I skipped one slide. Okay, it's not here. I go back again. Okay, so it is about the ongoing studies. And it's important to report, first of all, the included studies in the Cochrane review, because these are those providing the data. We can assess the risk of bias, and they will guide the conclusion of our systematic review. However, it's important also to be accurate with the ongoing studies, to map what the upcoming studies are focused on in terms of which population, which type of drug, or which type of other non-pharmacological intervention. And for example, in this review, it's an empty review. So it was published last year. We could not find any study to be included, but there are 15 ongoing studies, and these are described in detail in this review. So this is good, of course, for the clinicians in this case, but also for the researchers, because they can see what the most of the research is focused within this topic. Okay, and this is about the updates. So with this, okay, this is my last slide, which is about the sustained inflation against another topic. And you can see here in the red square, we published first 6 years ago, 2015, only 2 studies by then. Then after 2 years, we published an update with 8 studies, so a lot of publication compared to what was done in the decades before. And then in 2020, only 2 studies were published, but here a huge study was published. So it's important to look what Messier says about updating your review, because, and Carsten mentioned this, the living systematic review, for some topics might be needed to update every few months. For other, every 5 years might be enough. So it's important to invest time and energy in update when this is needed. These are my contacts, email, and then the contacts here at the Cochrane Sweden different media channel. Спасибо большое.
Большое спасибо.
Thank you very much. Thank you very much, Matteo. Thanks a lot. We are right on time, right on schedule. Thank you. So far, there were no questions, but the topic is of interest with beautiful examples. Thank you, Matteo. It's burning examples. I believe there will be more questions when we pass into group discussion. And now, in strict accordance with our schedule, thank you very much, Matteo. Thank you. Thank you. And now, we are continuing along this schedule, and it is my pleasure to give floor to Tony Aburo, the director of Cochrane Library.
Пока Тони подсоединяется, из чата уже могу сообщить, дорогие коллеги.
Tony is collecting. We are receiving a lot of thanks for Matteo on the chat.
Thank you, Lilia. Is that my cue to kick off?
Yes, we can hear you, Tony. Yes, please.
Great, thank you. Спасибо. So yes, thank you very much. It's a real pleasure to be here. Добрый день. That's the extent of my Russian now. Добрый день and спасибо. I'm going to talk to you today about Cochrane Library and the ways in which it is a unique resource of evidence. So let me just get my slides up for you. Okay, hopefully you can see my screen. Yes, good. Okay. So I've got a fair amount to get through, so I won't linger too long on the introduction, but my name's Tony. I'm a senior editor in the Cochrane team at Wiley. We are Cochrane's publishing partner, and I've been working in that team for a little over 7 years. Okay, so we're going to look at the Cochrane Library. What is it? How does it work? We're also going to focus on the users of the Cochrane Library, different use cases and different user types. Then we're going to think about why people go to Cochrane over the many other resources out there that you can access, what sets Cochrane apart. Then we're going to think about a few different problems in evidence-based medicine, in information in general, and how Cochrane reviews can solve some of those problems. And then I'm going to give you a few different ways that we measure the impact of the Cochrane Library around the world. And hopefully that will give you a sense of its global footprint. And then for the last sort of 5-10 minutes, we'll jump over to do a live demo on the Cochrane Library. I'll show you how to find a couple of useful things, particularly how to find translations in Russian. We may not have time for Q&A, I'm not sure, but please feel free to post any questions in the chat and I can pick them up later. And then I'm also moderating one of the discussion groups later as well, so please feel free to bring your questions there. Okay, so some of this will be very familiar to you, so I won't linger too long. But what is the Cochrane Library? It's a suite of different types of high quality, independent types of evidence that all in some way or another are geared towards helping people make better informed healthcare decisions. And you can think of it principally as three core component databases, and plus a few other things. So firstly, the Cochrane Database of Systematic Reviews, CDSR. This is where we host the Cochrane Reviews, the kind of flagship principal output of the Cochrane collaboration. We have about 11,000 reviews, and that's made up of about 8,500 full reviews and 2,500 protocols, which is the first stage of a review where the authors set out what they're going to do. Secondly, we have the Central Register of Controlled Trials, or Central. Central is a highly concentrated source of reports of more than 1.7, actually we might be at 1.8 million now, randomized and quasi-randomized controlled trials. It makes Central the largest repository of trial data in the world. And Central is published on a monthly basis. CDSR, I should have said, is published continuously. So as soon as new reviews are ready to go, we publish when ready. Central, on the other hand, published on a monthly basis. Thirdly, Cochrane Clinical Answers. So this is a database of almost 3,000 bite-sized, clinically focused article types built for clinicians. So this is where we take clinically relevant findings from Cochrane reviews and package them up in a way that's really easy for clinicians specifically to access the findings and also to explore the outcomes and PICO data from a Cochrane review. And I'll show you an example of one of those on the library later on. Beyond that, we also have editorials, which we publish around maybe one a month, thousands of podcasts in many different languages, lots of those in Russian, and also special collections, which are, as the name suggests, specially curated collections of Cochrane reviews around a given topic, say malnutrition or smoking cessation, or as you can imagine in the past couple of years, lots of different collections concerning COVID-19. Okay, so who are our users? The Cochrane Library has a wide sort of range of end users, and each of those with different needs and wants that can be met in certain ways by the Cochrane Library. So, for example, if we were in a teaching hospital, you may find that there are hospital administrators, or you will find that there are hospital administrators, people that are responsible for making and guiding policy for the hospital. And those people need to use the latest evidence to support decision-making and to inform new guidelines and ultimately best practice in the clinical setting. So that's where policymakers are setting policy at that level. That feeds down to healthcare professionals. So clinicians, doctors, nurses, other healthcare professionals who want to use the evidence from Cochrane reviews to principally to improve clinical outcomes, to make sure that their treatment decisions are based on the latest evidence that's up to date, as Matteo touched on, and also as a teaching tool, so to educate the next generation of healthcare professionals and make sure that those doctors and nurses that are coming through are employing evidence-based practice. You may also, in this setting, have a medical librarian, perhaps in the research arm of the hospital. Now, the medical librarians will use Cochrane reviews in the Cochrane Library to, firstly, to validate their research hypotheses and to determine the novelty of their ideas in a certain context, in a certain topic. They will also use the Cochrane Library to identify knowledge gaps. So this is an important use case of the Cochrane Library, to see what we know, but also what we don't know and where future research could be taken. And then, of course, not forgetting the patients and members of the public, members of the general population, who might use the Cochrane Library to perhaps debunk some myths around certain interventions that they've maybe read about or heard about in the news, in order to make better informed healthcare decisions about their own health. And also maybe a patient wants to research and understand their own treatment options and then have a better informed conversation with their GP. So many use cases, and the Cochrane Library meeting those in different ways. So why the Cochrane Library? It's not the only resource. Why do people go to the Cochrane Library, and why is it considered the gold standard? So yeah, as I say, the Cochrane Library is kind of internationally recognized in research and in clinical healthcare as the gold standard in evidence-based medicine. This is due partly to the methodology, the Cochrane methodology that's used in a Cochrane review, and the findings and the level of evidence that turns up. Cochrane are also entirely independent and advertisement free. Cochrane don't have conflicted funding from sort of pharma or corporate sponsorship. So that adds kind of even more to their credibility. Cochrane's methods, as I say, are not just used in Cochrane reviews, but the methodology types and the way that Cochrane go about it, these methods are widely taught and are adopted by the medical community, and in some places seen as standard practice. So ultimately, Cochrane Library is a trusted resource for medical professionals and policymakers around the world. I think this quote from a researcher in the UK sums it up quite well. So Cochrane is highly valued in the medical community due to the high quality and reliability of the information that it provides. If it's Cochrane, I don't have to think twice before using the data. Okay, so to take a slightly different angle now, we're going to think about some problems in this space, some sort of research and clinical problems, and how Cochrane reviews can address those issues and help our users. So we know that there's an immense volume of research out there being produced at an ever-increasing speed and velocity. So what issues does this bring up, and how can the Cochrane Library address them? Issue number one, the problem of conflicting evidence from single studies. So the rapid pace at which research is being produced means that there can often be single studies in a field that have different or sometimes even opposing conclusions from those studies. This makes it really difficult to get definitive answers, and it relies upon the reader to sift through those studies themselves to determine what's what. Now, the solution here is that in a systematic review, in a Cochrane systematic review, researchers they'll define a specific question. So, does keyhole surgery help with knee pain in middle-aged people? Does hydroxychloroquine prevent COVID-19 deaths? They then search for and collate all of the relevant evidence, all of the relevant high-quality studies that meet a certain eligibility criteria that can help answer that question, and then they analyze and pull those results in a Cochrane review. This helps to make sense of the balance of evidence when individual studies conflict. This saves, number one, saves the reader time, saves the researcher time, and it also can give them greater confidence in the evidence that they're using. Okay, problem number two, again, Matteo touched on this brilliantly. I think that example told it best, but the notion of evolving conclusions. So new evidence and new medical advances mean that healthcare recommendations can change over time. And it's difficult perhaps to stay up with all of those at once across the board. So the nature of updating Cochrane reviews means that Cochrane authors run new searches and find new evidence and highlight where conclusions may have shifted over time. Particularly methods used in living systematic reviews and rapid reviews have allowed for high quality systematic reviews to be generated quickly and address kind of urgent medical questions, particularly as we've seen in the pandemic, but also across other topics. Okay, problem statement number three is that the credibility of sources is sometimes uncertain. So again, with the vast amount of research that's available, it's hard to know which evidence to trust. Now, Cochrane's methodology are designed to rate transparently and publish the quality of the evidence that's included in systematic reviews, and also with a rigorous tool to make an assessment of the risk of bias from each of those included studies. This means that the reader can, sort of trust the research they're looking at, but also dig in detail and see the criteria and see the risk of bias and the makeup of the characteristics of each of those studies included. Okay, and then finally, the problem of the overwhelming volume of research. So we're living in a pandemic, we're also living in an infodemic, if you like. There's a lot of noise. There's a lot of noise from a variety of sources. The sheer volume is overwhelming. How do you keep track of that? So what the Cochrane Library does and what Cochrane reviews do is to consolidate all the credible evidence, all the, as I say, study data that meets a certain criteria into one summary. This cuts down that time. As that researcher noted, you can use a Cochrane review as a go-to piece for trusted evidence. Okay, I'll briefly touch on some of the ways that we measure the impact of the Cochrane Library, and then we'll have a good 5-6 minutes for me to do a live demo and show you a couple of features that I think will be really useful. Okay, so a couple of ways at Wiley that we measure the kind of impact of journals in general are your sort of traditional bibliometrics. Usage, how many people read it, and citations, how many other people are writing about your research. So the Cochrane Library in 2020 had around 15 million full text views from around the world, more than 230 countries. to all of the data in the Cochrane Library, most of that to Cochrane Reviews, about 86% of it, but the rest also to central records and to CCAs. And we see that usage continuously grow year on year. So lots of people around the world speaking different tongues, accessing high quality evidence from the Cochrane Library. Now, citations wise, the CDSR, the Cochrane database of systematic reviews, is a database, but it has characteristics of a journal. One of those being that it has an impact factor and has had for many years, I think since 2006, 2007. And it has a very strong one as well. So you may be aware of the impact factor. It's one of many we could talk about, but it's probably one of the best known indicators of citation frequency in scholarly literature. The Cochrane impact factor is 9.266, which is a big bump on 7.890. Actually, it's 9.289. It went up again in an update that Clarivate released in September. So, and that's a big jump on 7.8 the previous year. Another way to consider the impact of kind of CDSR citations, slightly different from the impact factor, is that a study that was done in the Journal of Medical Internet Research in 2019 found that the CDSR is the most referenced journal on Wikipedia. So we know that Wikipedia is one of the most popular, one of the biggest go-to resources for information in general. And of course, implicitly, that includes people looking for information about medical interventions. Cochrane have partnered with Wikipedia to try and, as often as they can, make sure that Cochrane evidence is underpinning pages about different interventions and healthcare topics on Wikipedia. And CDSR is the most referenced journal of any on Wikipedia. So that's been vastly successful. Next, alt metrics. So this basically means alternative metrics, alternative from usage and general citations. People talking about and engaging with Cochrane reviews. And that's grown dramatically, 70,000 mentions so far in 2021, which is really good growth on prior years. And then lastly, guidelines. So this is a really important metric for Cochrane, and it's a really good indicator of Cochrane evidence making a difference. So we know that as of 2020, Cochrane reviews have received more than 30,000 cites in all guidelines around the world. This is work done by Cochrane UK. Another way of looking at it is that each year we look at how many of the WHO guidelines published in a given year were informed directly by Cochrane reviews. Last year, 86% of those were informed by Cochrane reviews. So that's, again, indicative of another great partnership and also just a really important indicator of Cochrane evidence getting in at policy level and therefore creating better outcomes for patients. Okay, we'll jump now to the live demo on the Cochrane Library. Got about 4 or 5 minutes, so it'll be a whistle-stop tour, but I'll try and show you some of the best bits. Okay, so here we are on the Cochrane Library homepage. I'm going to jump straight into a Cochrane review. Let's use this recent one. I mentioned altmetric. This review here can, so ivermectin for preventing and treating COVID-19 is the highest scoring altmetric Cochrane review ever. It's got a whopping score of nearly 10,000 on altmetric. Lots of people talking about this and lots of people engaging with the findings. One thing I want to jump to straight away. So we know that a Cochrane review is a huge piece of literature, so we make that a little bit easier to navigate. For one, you can collapse and expand the sections and jump to different pieces. You can also do that on the nice right-hand side navigation panel to jump to different parts of the Cochrane review. So for this one, let's jump straight to the plain language summary. This is the lay summary where the authors try and make the findings accessible. So here, key messages: what is the intervention? What do we want to find out? How did we do it? What did we find? Now, this section, as you can see, is available in Russian. So if I click this link here and switch it over to Russian, the Cochrane Library will do so. So now I can see that the plain language summary is showing in Cyrillic script, and that whole section is now showing in Russian. Now, this is thanks to Cochrane Russia. You can see on any of these translations, you can look at translation notes and you will see here details about the translation, who provided it and how it was done. In this case, of course, from Cochrane Russia, which is very timely to celebrate. Okay, the other few things I want to show you on the Cochrane review is how you can jump to other evidence types. So we've got this section here of related content. I could jump over to an example of a CCA, a Cochrane Clinical Answer, and then also podcasts and special collections that this one's included in. So I'll show you that very quickly, just so that you can see the Cochrane review, ivermectin, and then how it's kind of adapted and rendered as a CCA. So this, as I say, is designed by clinicians and built for clinicians. And it's this simple kind of question and answer format with findings from the review. And then a clinician can dig into each outcome considered in that Cochrane review with detail on the PICO data, the population, who was in the study, the intervention, what was being measured, and the comparator, often placebo or do nothing, and then the outcomes, PICO, PICO. That data is really useful for clinicians to explore, and so we make that really easy to do. Another thing I want to show you very quickly, I think I've got about a minute left, is how to find Russian content in your searches. So because I switched the Cochrane Library to Russian earlier, it's remembered that that's my preference. So if I click up here, you can see that review language, this is where the extent of the translations are in reviews that are available in up to 15 different languages. The whole website is also available in Spanish, but we're not looking at that today. We're focusing on content. I'm going to switch it back to English just to make it easier for me to navigate. And then I'll show you very quickly how you find this in the search. So if I run a very basic search for, say, blood, we're at 10:05, so I'll use the remainder of this minute to show you this feature, and then we'll leave it there. So I can see that for my search term, there are 2,500 reviews. And if I look down the left here and expand the language options, I can see that 882 of those include content that's available in Russian. So if I apply that filter, I then can see my results, and then any of these Cochrane reviews that I click into, when I get there, I'll be able to find content in Russian. So again, this one, it'll be the plain language summary. And when I get there, I'd have the option again to switch it into Cyrillic script. There we go, and consume the content in Russian. Okay, I'm just over, so I'll stop there. Spasiba.
Большое спасибо, Тони.
Thank you very much, Tony. It was a wonderful presentation. It was a wonderful live demo of the Cochrane Library. And we are very pleased that our translations into Russian contribute to the developments of the Cochrane Library. And we do hope that our future cooperation will be even more productive. We do have questions for you, but we need to proceed with our agenda, and I think that we will ask you questions during the group discussion and during the final discussion. Can you hear us, Tony? Well, I hope that...
I think the time is passing. Thank you very much, Tony. I see from the question that our listeners were extremely inspired, and I can just read. Thanks to Tony. Thank you, Tony. Very interesting. And our listeners are asking if it's possible to see the recording. Yes, you will have this opportunity. And the rest of the questions will be discussed at the discussion. Thank you very much, dear colleagues. Thank you very much, Tony. And now it is my pleasure to give the floor to our next speaker, who will present the situation in the Russian Federation, Vlada Fedyaeva, Director of the Department on Clinical Recommendations on the Center of Expert Knowledge for Medical Activities. Just a second. She's the head of the Department of Methodology and Clinical Recommendation in the Expertise Center of the Quality of Medical Care, Vlada Fedyaeva. The floor is yours. Good afternoon, dear colleagues. Thank you very much for the opportunity. Please let me share my screen. Do you see my presentation? I hope you do. Yes, everything's okay. I will briefly share about clinical recommendations in Russia. Since I don't have much time, I'll try to be very brief and to the point. Currently, clinical recommendations are occupying central place in the providing of medical health assistance in Russia. The amendments have been brought into federal law on healthcare, and besides clinical recommendations being central, they are now the foundation for different documents which are regulating healthcare. First of all, standards of medical care, standards of healthcare developed on the basis of clinical recommendations, which are the part of state guarantee program, and criteria for estimate of the quality of healthcare, which will be used as of 2022 to estimate the quality and financing of healthcare statistical groups. So clinical recommendations are the most important link in the entire system. In the federal law 323 states that contains the definition of clinical recommendations, which is that clinical recommendations are documents containing information based on scientific evidence about the prevention, diagnostics, treatment, and rehabilitation. That means that a factual evidence base for clinical recommendations is now mandated by the law at the highest level. Requirements for clinical recommendations include that the information on the issues of prevention, diagnostics, treatment, and rehabilitation should be included in clinical recommendation based on the evidence-based medicine principles. And this is also part of the Decree 103N about the terms of development of clinical recommendations, their review, typical form, composition. This is the document that regulates all the requirements for clinical recommendations. I will not dwell on all of them in detail, but I will describe in detail the structure, evidence-based structure, which is the foundation of medical recommendation. In fact, the main function of evidence-based is to estimate scientific value and the level of the probability level, which is the part of recommendations. All medical interventions should be stated, and it has to answer three questions. What should be done, to whom it should be done, and what's the purpose of intervention. Based on this information, you select evidence-based, which is answering this or that item throughout all the parameters: patient's population, medical intervention, and the purpose of medical intervention. Therefore, all the items of medical recommendation should be evidence-based to prove their validity and the level of recommendation. Another important issue I would describe is the functions of evidence-based. The provide the evaluation of efficacy and safety of medications which do not which are used off-label. The estimate of scientific validity in clinical recommendations. First of all, based on the recommendations, we are looking for the evidence based level according to the metrics. There are separate metrics for diagnostic intervention and for all other interventions. Why it's subdivided? Why this subdivision? Because diagnostic methods sometimes are estimated in a different trial design, which have their own structure and hierarchy, which may not be ignored when creating the validity scale, estimating evidence. Cochrane systematic reviews are different. Sometimes they vary in form for diagnostic intervention and clinical intervention. Diagnostic interventions are, and their methodology is estimated according to one set of tools, while everything else is using other tools. As for the level of proof of recommendation, the same way it's done in Cochrane, all the levels are estimated with taking into account the research where the evidence is taken from. These requirements are part of the decree of 103. They're fully adhered to with the introduction of the decree 103 into clinical recommendation practice. All clinical recommendations are now having similar methodology, estimating the scientific base. While prior to 2019, all clinical recommendations in Russia have been different, including the way to estimate their scientific validity. This introduction of these norms results not only in the increased quality of documentation, but also makes them simpler for representatives of different disciplines to understand, because they all see the same information. As for off-label usage of medications, it's a huge topic, because now off-label means the usage of medications outside of indications, or in case of counterindications, or in different dosage or application form. These recommendations might be part of clinical recommendations, but they're not part of healthcare standards. Clinical recommendations mandate the inclusion of off-label medications. First of all, you have to put this grid sign before the title and include the way of application, dosage, length, etc., etc. All the relevant information should be included, beside the fact that the mode of application is used for the medication, but this mode of application should be confirmed by the sources which confirm efficacy and, what is also very important, safety of such application for the given category of patients for which it is recommended as off-label So here, the evidence base here is the text of clinical recommendations, because the instruction, the label instruction, does not contain this information about applicability of this medication for this category of patients, as well as the information on efficacy and safety. Nevertheless, now the Russian Parliament, the State Duma, is considering the draft of a law on off-label usage of oncology drugs for children. However, so far the status of this decree is not quite clear. It's being reviewed. The draft is being reviewed for a while, but so far we don't know what are the results. We have viewed Cochrane review for clinical recommendations. Here we see brief stats. For example, now in clinical recommendations of the Healthcare Ministry of Russia, there are more than 300 clinical recommendations approved by the specialized council on the basis of Healthcare Ministry, which is not part of the ministry. 138 clinical recommendations of all 300 approved include 745 Cochrane reviews. These 138 clinical recommendations are from 25 profiles of healthcare and average 5 reviews per recommendation, including Cochrane reports. So overall, on all the recommendation, it means that there are 2 reviews per clinical recommendations. Is it much or not so much? It's not up to me to judge. On the formation of evidence base for clinical recommendations, full responsibility lies on the developer of clinical recommendations. Only the developer of the recommendation defines the rules and evidence base. If we go back to the previous slide and to scientific validity of evidence, Cochrane reviews, Cochrane systematic reviews have validity level 1. Sometimes there might be cases when non-randomized trials are included, but our practice showed that either there are none, or we can say that all Cochrane reviews are the reviewing randomized trials from the point of view of reliability of evidence and from the statistic power of this review of these trials. They are the leaders. The next slide presents general distribution of clinical recommendation according to their profiles, the number of reviews, and the average number of Cochrane reviews used per recommendation. Here we see that the leaders is obstetrics and gynecology, including 202 Cochrane reviews for 23 recommendations, average 9. Geriatrics have the highest average number of reviews per recommendation, namely 13, the right column. One has to say that there's not a complete list of healthcare profiles for which clinical recommendations do exist now. Not all the profiles and not all diseases may be studied through randomized trial, and not all interventions may be studied through randomized trial. For example, emergency care or orphan diseases when randomized studies, randomized trials are difficult. So one may not say that all other profiles which do not include Cochrane systematic reviews or any other meta-analysis are wrong. We can't say it. Not always do we have sufficient evidence base for such research. Therefore, in our opinion, it's not a shortcoming of clinical recommendations, especially that the requirements for observance of high-level clinical recommendations currently do not exist, and healthcare, according to the law, has to be provided on the basis of clinical recommendations in general, without any subdivision on validity. So there are no criteria of levels. So I would say that majority of clinical recommendations include Cochrane reviews. The formulation of clinical recommendations is not completed. The evidence base is updated with new studies and new trials being reviewed, but this is the current picture. Let me finish. If there are any questions, I would be happy to provide answers. Thank you very much, Vlada. It was a very interesting report and very urgent, and it has generated a number of questions. We have 2 minutes. Let me read a few of the questions to you that I have received. Let me state them. I didn't say thank you very much, Tony Aburo, for a very useful presentation. And the other question is for Vlada. Vlada, how healthcare professionals may influence the quality of clinical recommendations. Healthcare professionals may influence the quality of recommendations, which is mandatory. There are requirements for a public discussion of at least 1 month of each clinical recommendation. This public discussion is organized by the developer of CR, of clinical recommendations. However, there are no the place of this discussion is not mandated. We say that the National Medical Chamber is the wonderful site for such discussion because it includes a number of interdisciplinary specialists, including those working in laboratory diagnostics, pathoanatomists, etc. So this is the process may take place at the stage of public discussion. Thank you very much. I think you are satisfied with an answer. There are more questions, but we will postpone them for the discussion. Thank you very much, Vlada. I was highly impressed with the numbers of the usage of Cochrane systematic reviews in the development of clinical recommendation. It's really very impressive, and I believe it reflects progress in this important issue which you are heading. Thank you very much. Dear colleagues, now it is my pleasure to give the floor to the member of Cochrane Russia, our dear colleague, Professor Pavlov.
Исследовательское и клиническое критическое мышление. И разрешите более подробно представить вам Чавдара Савовича Павлова.
Please let me introduce Chadar Pavlov. He has a doctorate in medicine. He is a professor, member of the Hepatobiliary Cochrane Group. He is head of the Internal Medicine Department in the Institute of Professional Development. He is a deputy research fellow in the Sechenov University. He is head of the Innovation Therapy Department in the Sechenov University in Moscow. Thank you, Lilia, for a very kind introduction. When we started, during the first event, our audience was a lot more modest, but today we had so many delegates that it led to a Zoom collapse, a website collapse, so we didn't have an opportunity to have a discussion, but it means that we have so many interested people that we will have a lot of followers, and the previous speaker talked about the number of Cochrane reviews. So I would like to ask the previous speaker the question, how many authors of these reviews are from Russia? She didn't give us the statistics, but I would like to say that the Sechenov University contributes a lot to the development of evidence-based medicine, to the development of medicine in Russia. So we are focusing on producing systematic reviews, of producing meta-analysis, and I would like to tell you a little bit more about the work that we do today. I hope you can hear me well and see my slides on the screen. So, dear colleagues, I would like to say that, of course, there is a background to every story. So when it comes to medicine and when it comes to clinical medicine, I would like to say that when it comes to medicine, medicine is a profession. Medicine as a profession was always related to art, to intuition, and medicine meant that the skills are transferred from the mentor to a mentee. And today, we can say that this paradigm, which existed for a long time in academic medicine, well, this paradigm today is shifting, and any doctor needs to have knowledge and combine this knowledge with hands-on clinical experience. So, of course, if you look at history, medicine used to be part of the sacred knowledge. The scholastic in the Middle Ages was at the foreground. Then medicine was slowly but surely becoming more research-oriented, so it was utilized not only by the church, but by the public science and culture. So what is critical thinking? And why does Sechenov University take an interest in critical thinking? Because, as you know, Francis Bacon said that critical thinking is a desire to search, tolerance to doubt, a love for thinking, and so on. So if you look at this quote from Francis Bacon, you will probably realize that everything that he talked about resonates with today's methodology, the methodology that we use as part of our Cochrane collaboration when we're developing systematic reviews and meta-analyses. So this paradigm that appeared in the Middle Ages went through further development. German universities in the 19th century developed a new concept. The German model was utilized by British universities, and of course in Russia we also integrated this German model. The German model meant that a student needed to do research independently, needed to experiment independently under the supervision of the mentor. At the start of the 20th century, and especially at the turn of the 21st century, with the appearance of internet, the attitude toward critical thinking has shifted somewhat. And this attitude becomes more of a cognitive skill. On my slide, you see the timeline of these developments. Starting from the turn of the 21st century, we see a lot of critics who are very outspoken about the fact that this methodology is removed from practical knowledge. In our university, we developed a roadmap. This roadmap was approved back in 2015, and now we are developing the 2030 program. There is also a program to develop new educational content for our medical students. And one of the main postulates that we base the new methodology of teaching medicine on is critical thinking. And we also very seriously view research and educational activity. I would like to point out one important fact. Of course, we all need to be capable of critical thinking. But apart from critical thinking, every time when we have doubts at any point in the learning of medicine, we need to apply logical method that allows us to dispel the doubt. So here you see Cochrane methodology. You are all very familiar with this concept. So this is a quote from David Sackett on the left side of the slide, and you see different competences, professional and general competences, which lead to unbiased evaluation of risks, which eliminates any bias when it comes to research. And of course, students need to be capable of independent thinking. They need to be able to ask questions and to critically evaluate answers to the questions. Now let me talk a little bit about our practical approach. So our main approach to the training of the students means that we utilize evidence-based medicine. We make sure that our students have the skills, they have the knowledge, they know of expert opinions, and of course, we utilize randomized clinical trials, and it is a great thing that our students have access to the results of clinical trials and are equipped to evaluate the results objectively. But, of course, we also have a number of issues. there is a serious problem when it comes to clinical application of the knowledge that is gained through generalization and systematization of the results of clinical trials. The information channels that we use sometimes do not deliver the most reliable results. The methodology to evaluate the efficiency and the safety does not deliver the results very fast, which we witnessed during the COVID pandemic. It takes time. When it comes to Cochrane systematic reviews and meta-analysis, I have to say that these are reviews and meta-analysis which are of the highest methodological quality. A lot of speakers have already emphasized this fact. On this slide, you see a picture of one of the founding fathers of the evidence-based medicine. Cochrane Library was named after him. What are the advantages of publication in the Cochrane Library? Well, you're all aware of the advantages, so I will not talk about it, but let me tell you about the program 2030 that has been implemented in the section of universities. So what does this program include? Well, it includes a lot of important elements, and by the way, we tested all of these elements as part of our pilot projects. So we need to harmonize our educational program with educational programs of the leading research centers in the world. We are going to introduce the credit system into the learning process, so our students will get learning credits. It is going to be a module-based system. We're going to have 3 levels of educational modules. We're going to have a foundational or introduction module, a foundational module, and an advanced module. During training, our students gain project-based skills. They need to know about the basic project principles, and they need to utilize scientific and academic approaches. So our Institute of Clinical Medicine launched a pilot project a couple of years ago. This pilot project included 3 modules. You see the number of hours that we allocated for each discipline, and you see the knowledge that we are expecting our students to have at the end. The next course, or the next level, is a level that's intended for our postgraduate students, for our interns and research associates. And again, this is a course that has 3 educational modules. So number 1 is Introduction to Systematic Reviews and Meta-Analysis. Number 2 is writing the protocol of systemic review and meta-analysis. And there is an advanced course which is writing and publication in the Cochrane Library of systematic reviews and meta-analysis. So you see the content of the curriculum of our advanced educational course. And when the students go through this educational course, they learn how to work with the Cochrane system. Well, we have other programs. For instance, this is an MA program. This is a program for pharmacists, and For people who work in the medical business, you see the main components of the program listed on the slide. And this program also includes a module for postgraduate education. And this module is called Straightforward Answers to Complicated Issues in Evidence-Based Medicine. So here we provide our students foundational knowledge in evidence-based medicine, and we teach our students how to utilize the methodology that is needed to improve their utilization of clinical guidelines. We also have educational simulators that allow to use everything that students learn in practice. So we have a system which is called Section of DataMed. So our students, our young research associates and our interns can utilize Section of DataMed systems, and they can also use the system to publish their systematic reviews and meta-analysis. What results have we achieved utilizing this multi-level system? On this slide, you see the number of articles in the Cochrane database. You see different presentations delivered during poster sessions and conferences. So that's everything that's been done by our students. My colleagues also collaborate with Cochrane, especially in those areas that are of interest to us. Each healthcare system has specific areas of interest. So on this slide, you see the scale of our contribution. You see our contributions, which are interesting from the research and academic point of view. We are providing evidence for different medical interventions or diagnostic methodologies, and all of these systemic reviews and meta-analysis are written together with the participation of people from our university. If you have any questions, I'll be more than happy to answer. Thank you very much for your attention.
Thank
you very much. We are doing really well with the time. So if you allow us, we will shift the questions to the group discussion. Thank you very much, Chadar, for a very interesting talk. Thank you very much for a very kind introduction. Thank you very much for collaborating with our university, and I think we will continue our collaboration. And our collaboration will involve our students, our young researchers. By the way, I didn't mention that we published our first dissertation, and this dissertation was about the use of Cochrane methodology to evaluate the safety and efficiency of medicines to treat chronic liver diseases.
Что действительно будет очень много успехов на этом пути у нас с вами вместе и, конечно, в Сеченовском университете в обучении студентов, будущих врачей. Спасибо, спасибо большое, Чавдар Салович. А сейчас, дорогие коллеги, мы идем по нашей программе.
And now, dear colleagues, we are proceeding with our program. It is my pleasure to give the floor for the presentation on the evidence-based knowledge as a basis for clinical decisions to Yelena Kleimenova, Doctor of Medicine, Professor of Chair of Clinical Pharmacology and Therapy of the Russian Academy of Continuous Medical Education, Head of Bank of Russia Medical Center, which is the basis for our academy. Thank you very much, Yelena. The floor is yours. Thank you very much. I would like to thank for the opportunity to participate in such very interesting and useful event, both of you. And I will talk about the introduction of evidence-based knowledge into the clinical practice. I represent the medical center of the Bank of Russia, and my over 10 years of experience of introduction of evidence-based knowledge into the work of this organization, I would like to share with you. I will not dwell on the issue of translation of medical knowledge, because this has been mentioned in every report to some extent. However, when reviewing the introduction of evidence-based knowledge in clinical practice, we have to take into account the processes which take place in the medical organization. In order to illustrate, such a metaphor as a brush has been suggested, where all the processes have been subdivided into standard, routine, and non-routine. Standard processes have low in definition. For example, washing hands, nobody's discussing it, and the only task of the leadership of medical organization is to mandate the application of this mandatory process. Routine are cases where different options of treatment depend on zoology and nosology and the condition of a given patient. Currently, there isn't experience of using automatization of clinical decisions, and non-routine processes are unique cases with high degree of in definition, where the best option is not known yet. So usually it requires consilium or using technologies of evidence-based medicine, searching for answers in the corresponding resources. Introducing clinical guidelines into work, one should take into account the context of medical organization and adapt the documents to this context. We have to take into account the staff structure, services provided, material base, technical base, in order to adapt these documents for usage in a given organization. In our organization, we have opted for creating of adapted standards based on standards of healthcare ministry, clinical guidelines, and quality criteria. Here is an example of adapting of medical standard for sinus node deficiency syndrome. We can only now develop domestic recommendations. And an important stage is the process of analysis of their practical usage. That's what we are currently doing. We are monitoring the scope. Altogether, we have used 113 adapted standards, and average scope of standards usage is 70% of all patients, fluctuating depending on the number of clinical recommendations for different profiles, clinical guidelines for different profiles. And it's important, auditing is important. About 15% of guidelines are audited. When we see deviations, we state them in our conclusions. Another important task is securing safety safety in hospital infection. The important thing is that it's not only they contain the standards describing the responsibility of all the process participants, but they have to analyze the implementation. That means practical implementation and the frequency and 100% auditing of any complications. We use the care bundle approach as part of standard operation procedures. This is the complex medical services from 3 to 5, which are mandatory for the certain category of patients. Each component of this complex must have evidence-based proof of improving the outcome. And the estimate is done on all or nothing. Partial is not counted. Here is an example on the efficiency of care bundle for the prevention of ventilator-associated pneumonia in children, which in the review has demonstrated the efficacy. These care bundles were integrated in standard operation procedure. How the application of care bundle is checked. Checklists are used widely. List of WHO, which is widely used, approved by the experts, has good evidence-based base. Definitely for the safety, we cannot rely on randomized trial sometimes. The review presented here included almost 500,000 patients from 27 countries and 497 hospitals, which allowed to decrease post-operation complications by 27%. It is important just to state that we have introduced this or that practice, but we have to follow it. Here is the list of indicators that are monitored on a regular basis. And also automatization is important, because manual control is very complicated. Mechanisms of decision-making are the tools of management of medical organization, and they also allow to introduce them on a more efficient basis. The efficiency of the decision-making process system has been proven. This is the results of review using of 108 studies, 94 randomized, 14 quasi-randomized, and the support for decision-making was also the prescription of medications, vaccinations, medical documentation, etc. We have developed our own system of decision support, which is configured by the user, module build, and performing the following functions, aimed at the inpatient complications, taking into account the risk factors of the inpatients, including automated auditing, whether the hospital is running prevention of in-hospital complications, which allows to run business analytics. This configuration allows to automatize clinical leadership, especially in interdisciplinary areas, of which patient safety is one of them, and to update at least once a year. It is very easy to organize internal control and to use it for staff training. And as for non-routine processes, non-standard situation when the diagnosis is not known or we don't know the clinical picture, besides Consilium, we can search for the data in scientific literature, including secondary resources, Cochrane database, Dynamed, and UpToDate, which we are actively using. Therefore, we have developed a standardized form of questionnaires, clinical questions. Here is the plan of discussion of these clinical issues at doctors' conferences, search in different resources, critical analysis, and applicability for a given case. Here we see the fragment of the system where we introduce the data. This practice, analyzing clinical cases with usage of evidence-based medicine, is also the promotion of evidence-based medicine in the hospital and attracting the attention of physicians to the use of this technology. Here are partial titles of reports and topics reviewed at our doctors' conferences. And the last one, I want to say that we are introducing IT technologies in medical practice, and definitely they are the important factor of increasing the efficacy, safety, and availability of medical care. At the same time, we have to emphasize that the introduction of digital technologies should be evidence-based. This, as the instruction of WHO says. I'll bring a couple of examples. Definitely, there is no doubt in the need to introduce electronic medical cards for the patients, but prescriptions and when planning the introduction of information technologies, each medical organization has to include this evidence base into account in order to provide the most efficient introduction of such technologies. And the last example, practically all medical organizations are introducing barcodes in labeling of drugs. They're mainly used for the control of inflow of drugs to the pharmacies, but this technology can be used also to secure the safety of drugs if it's synchronized. And in conclusion, I would like to bring another metaphor. Here is the water pipe, the tap. Using evidence-based medicine, we can receive only 20%. So introducing evidence-based, we have to take into account all the possible leaks and run the complex of measures to minimize the leakage. The last is the support of the decision and patient's training. So the introduction of this process is an important component. Thank you. Thank you very much, Yelena. It has been a very interesting public and unique report. This opinion is shared Thank you, Yelena. Your report opens new opportunities for both young and experienced professionals. There are questions. We do have time for one question. And a lot of thanks goes to Yelena Klemenova for her presentation. Thank you very much, Yelena. This was a wonderful presentation. And definitely, we have to share your experience in the healthcare system at large. There is a gap between clinical recommendation and their implementation, and as well as paid by and insurance payment. There is a gap between recommendations and insurance payment. There's a challenging question. There's a challenge. We have to look at the opportunities of a given hospital. We have to take into account the opportunities of a concrete hospital in applying recommendations. What I have mentioned means adaptation. I understand there are limitations, so I can't answer this question because I do not distribute the available resources, but the way how to optimize and adapt it for the concrete organization to develop this tool, adapting it for your organization. What I tried to show is the answer to this question. We are applying concrete technologies, adapting them to our capacity, to our capabilities, in order to make this process most efficient.
Примеряет эти возможности и позволяет именно в наших условиях все это реализовывать. Это точно пример, необходимый к масштабированию. Я отдельно от организаторов хочу поблагодарить вас за англоязычную презентацию и подчеркнуть для наших слушателей и наших иностранных спикеров и гостей, что была возможность посмотреть вашу презентацию как в русскоязычной версии, так и в англоязычной версии. Это было в трансляции. Нам здесь не было видно, Елена Борисовна. Большое спасибо. Большое спасибо. Дорогие коллеги, вот как раз и подходит наше время, и мы переходим к последнему докладу, но ни в коей мере не менее важному. Очень
Okay, so we are moving to the last talk, and it is a great pleasure for me to introduce Alexei Kolbin, who will talk to us about RWD, RWE, the current situation in Russia. So it is a great honor for me to introduce Alexei Kolbin, head of the Department of Clinical Pharmacology and Evidence-Based Medicine in the Pavlov St. Petersburg University. Over to you, Alexei. Thank you very much for giving me an opportunity to deliver a talk on a topic. So, what launched the RWD, RWE concept? What was the first reason that initiated the discussion? Well, here you see a photograph of a man who we mentioned many times today. He lent his name to a very renowned organization, and he said that between measurement based on randomized clinical trials and benefit in the community, there is a gulf which has been much underestimated. So he was absolutely right. It is a great gulf and a great divide. I would like to remind you when we register a medicine during interventional clinical trials, we're looking at the so-called efficacy. And the main tool that we use to evaluate efficacy is conducting randomized clinical trials. We can synthesize information through systematic reviews or through meta-analysis. Then we use the tools of evidence-based medicine and we approach our regulators. So on my slide, I highlighted in blue what we study in the real-world data, in the real-world evidence processes. So we utilize randomized clinical trials, and in orange on my slide, I indicate evaluated what it is that we use to evaluate the situation in healthcare, and there is a huge divide between efficacy and effectiveness. It is true, today we have a lot of tools in our armamentarium to measure efficacy and effectiveness. Of course, evidence-based medicine is rooted in efficacy and meta-analysis. We have a wonderful GCP system to evaluate the efficacy. But when we're talking about effectiveness, we have a lot of questions. We do not have a lot of practices that are available to us. And in 1995, a whole concept was developed that talked about the gap between efficacy and effectiveness. In 2016, 3 reasons for this gap were outlined, and during my talk today I will not talk in detail about the reason for this gap, but we do know that the explanation of this gap was provided back in 2016. Instrument to minimize this gap in the concept of RWD, RWE. This is an area of medicine that is rapidly developing all over the world. It is developing simultaneously in the USA, Canada, Scandinavian countries, Sweden, China, Korea, Japan, Taiwan, in Europe. So we see that all of these authorities issue documents pretty much at the same time. Here in Russia, we do not have a legislative definition of RWD and RWE, but we did develop a definition in the Eurasian Economic Union. We're very close to developing a final definition. We've already jumped through a lot of regulatory hurdles, and the experts believe that at the start of the next year, we will have the final definition. So what is RWD? RWD are real-world data related to the health of the patient or the provision of medical care. This data is generated from different sources, and RWE is defined as clinical evidence regarding potential benefit and harm gained from real-world data. Again, I would like to highlight that we do not have a final definition in the Russian Federation, but we do have a post-registration clinical studies. We have post-registration safety studies, and we have registers, but it is difficult now to interpret the results we get from the patient registers. When we talk about the legislative database for RWD and RWE in Russia, these trials can be interventional or observational, and they can only be initiated by the holder of the market registration. So number 1, these trials are conducted to introduce changes to the label of a medicine, to refine data for effectiveness and safety, and these trials are conducted to confirm the market registration of a medicine. And of course, we have a number of key issues that need to be resolved in Russia. Well, here we have excessive regulation for observational trials. We have some issues on interpreting data from the registers. We have issues related to pharmacovigilance. Russian pharmacovigilance system is closed and is difficult to be analyzed. We're talking today about clinical guidelines, but we cannot utilize real-world data in clinical guidelines, and there are certain limitations as well. On this slide, you can see the global consensus about RWD. RWD are data registers, data provided by pharmaceutical companies, data from electronic personal health records. So we gain RWD, then we can turn them into RWE. and that can introduce changes to the drug label, changes to pharmacovigilance and reimbursement schemes. Our Chinese colleagues suggested a very clear schematic how to collect data for RWD, how to evaluate it based on evidence-based medicine to get RWE or a valid RWD. Currently, we have two types of trials that we can use for RWD, RWE, which is a large simplified randomized trials and pragmatic clinical trials. So this is something that is being also used by WHO, doing simplified clinical trials for COVID. When it comes to non-interventional trials, we have cohort trials registers. We can use questionnaires to collect health data. Let's use COVID as an example. For instance, the effect from a medicine used for COVID is now studied in the US using cohort-based studies. And if we look at the US experience, then we see the effect from a medicine in real hospital conditions. Well, the design of the trial is cohort with parallel groups. Unfortunately, in the Russian Federation, we do not have a national trial of medicines used for COVID therapy. And of course, we have evolution from RWD to RWD. Not all RWD will become RWE or valid RWD. We need a system here. The great system was a little bit overlooked, but I think now this is the time for the rebirth of GRADE, and it is correct that when we create variable guidelines that WHO is developing for the treatment of COVID, well, these guidelines use GRADE methodology and the PICO methodology as well. And of course, when it comes to the Russian hospital, when it comes to our departments, we cannot use all RWEs. They might not be applicable in our real settings or in our real departments, and it's not a Russia-specific problem, it is a global problem. So currently in the world, we have 5 tools to validate our RWE for specific hospitals or specific departments. You see the list of these tools on the slide, so in the interest of time, I will not tell you about these tools in detail, but there are some studies available talking about advantages and disadvantages of these tools. One of the advantages of these tools is they're all open for public use, but I think Russia needs to come up with its own tool. Therefore, what is the situation in 2021? Initially, RWE was offered as a method to bridge the gap between efficacy and effectiveness. But now we can say that RWE is used in the development and study of medicines, especially during the COVID pandemic. There are hybrid trials that are used to register medicines. Also, we can use RWE to gain additional information about safety and effectiveness. And number 3, we can use it for HTE, for reimbursement, and for the distribution of risks, especially when it comes to orphan drugs. Let me give you an example from pharmacovigilance. Here in green, you see a pharmacovigilance system, which was developed 50 years ago. It was developed for small molecules, and most at the time the system was adequate. But today we do not only have small molecules, we also have biologicals, we have gene-based therapy, we have cell-based therapy, for instance CAR-T cell therapy. Therefore, the current pharmacovigilance system, which is based on spontaneous messages, which is based on creating national and international databases of adverse events. And of course, we needed new system of pharmacovigilance. This system has been suggested. This system analyzes electronic health records, the data of insurance companies, as well as electronic national systems such as Sentinel from the United States. And therefore, RWE is the foundation of new pharmacovigilance systems which are being used in some countries globally. Of course, there is an experimental system of pharmacovigilance, and the patient is at the foundation of this system. The patient, of course, the system has many different devices, different applications. Many experts criticize this experimental system, but probably in the future that's what we're going to have. When it comes to Russia, in 2020 we published recommendations on RWE. So you see a long list of authors here. These authors are usually clinical pharmacologists, and these recommendations are published under the aegis of the Russian Association of Clinical Pharmacology, under the supervision of Mr. Petrov, the member of the Russian Academies of Sciences. We registered my RWD magazine, so we already published the first issue of the journal. Please do contribute to the journal. It is an electronic journal. It is an open journal, and what's important is that it is a bilingual journal, available in Russian and English. We also organize international conference. The first conference happened in 2020. It had 24 talks. All talks are openly available. The second conference was organized this September. We had 32 talks, and we are starting to publish all of the materials in Russian and English. All of the materials are available absolutely freely, and we do hope that we'll finish uploading all of these materials soon. The Eurasian Economic Union does a lot of work. We polled all of the member countries on RWD, on RWE. We did 2 analytical trials to attempt to change existing regulatory acts, so we can introduce some amendments, and we also suggested amendments to the legislative framework of Eurasian Economic Union. We have embarked on developing the concept of RWD, RWE for the Eurasian Economic Union. To conclude my talk, and also in the interest of saving the time for group discussions, I would like to talk about conclusions. So, real-world evidence is an international trend. We need to ensure the quality of trials of RWE and RWD. We need to develop single methodology for all of the participants. We need to develop quality standards. We need to develop Russian tools in order to evaluate RWD for decision making. These are the tools for all of the hospitals and departments. And number 4, the government strategy when it comes to healthcare and the development of information and communication technologies in healthcare, of course, will lead to the increase in the number of sources of RWD and RWE. So we need to use this government strategy to further develop RWD and RWE in Russia. Thank you very much for giving me a chance to talk at this conference. Thank you very much, Alexei. That was a very interesting talk. It was really forward-looking presentation. You talked a lot about the prospects and possible collaboration within the Eurasian Economic Union. We do have a little bit of time, so let me tell you that the audience is thanking you for your talk. And there is also a question. Experimental pharmacovigilance system, is it part of the experimental legal regime? No, the experimental pharmacovigilance system, as far as I know, it hasn't been implemented anywhere. It is currently being discussed by experts. The experts came up with these suggestions for the structure of this experimental pharmacovigilance system. And each component of this system, you saw the schematic on my slide, is being scrutinized. Right now, we see a lot of analyses. We already have results from Estonia. They analyzed adverse events for patients who have to wear a device which transmits information, let's say, about blood pressure or about heart rates, or it transmits data on blood sugar level or HbA1c, and this data is compared to the data from patients who do not wear any devices, and they analyze the frequency of adverse events in these patients, because these patients are taking medication to address their underlying condition. So nobody has implemented the system yet, but the second direction of experimental pharmacovigilance is the analysis of what's going to happen if we use social media as a source of data on adverse events. And that is also something that is being analyzed. A lot of people are saying that it is very dangerous to use social media to decide whether a patient has adverse events or not. So this is something that is being discussed, and maybe it will be introduced because the information process is like an avalanche. The devices have been integrated into healthcare systems everywhere. Thank you very much, Alexei. We have about 90 seconds left. We do not have any more questions from the audience, but I do have a question. What about adverse events related to devices? Are they being studied in any way? Well, we all know that medicines are of primary concern. When it comes to medical devices, they're more of a tier 2 when it comes to clinical trials, medical devices are number 2 in the HTA system, and there are a lot of issues about correct evaluation of medical devices. And of course, they're priority number 2, maybe even priority number 3 when it comes to pharmacovigilance. So there's a lot of debate on this issue, but it is a very complex issue. Even the methodologies are very complicated, let alone the results that we gain using the data transmitted by these devices. I think it's too early to talk about it. Thank you very much. Thank you very much, Alexei. Thank you very much, Alexei, for your talk and for answering the questions. Dear colleagues, we have finished with our program for today, but now is the time for our group discussion. All of you who are registered on the platform should have a link to a Zoom session in the chat. It will be one room on Zoom, and then out of this room, we will split you into breakout groups, but we send you emails with the new link, not the link that you had previously. It is a new link, and we hope that with this new link, we are not going to have the technical difficulties we had using the previous link. So, dear colleagues, we are going to have a couple of minutes so to let you join using the link.
Чевдарасавовича нет, да, тут было к нему несколько вопросов, но я зачитаю так. Мы с Владой Константиновной все вопросы обсудили. Вот комментарии по диагностическим тестам тоже. Если я чего-то упускаю, с Тони мы тоже все обсудили, дорогие коллеги. Да, был вопрос ко мне, вот я пока этим займу время. Скажите, пожалуйста, в чем заключаются ключевые различия между доказательной медициной и поваренной книгой с потрепанной шляпой? И почему именно эти наименования выбраны вами как противопоставляющиеся доказательной медицине? Спасибо большое за вопрос, он очень интересный. Это вопрос относится вот к той ссылке на легендарную на сегодняшний день публикацию Дэвида Саккета о доказательной медицине с ее определением. И это были те годы, 96-й год, когда доказательная медицина еще была на этапах своего признания в Великобритании, уважаемые коллеги. И были противники ее внедрения, которые сравнивали ее со старой потрепанной шляпой. Почему? Потому что говорили, что пока вы составите свой систематический обзор, мир уйдет далеко вперед. Поэтому это все очень устаревшее, это все старое. Поэтому старая потрепанная шляпа. Однако на сегодня, я думаю, именно сейчас в пандемии кокрейновские обзоры и кокрейновское сотрудничество несомненно показало, как быстро, но со временем могут шагать систематические обзоры в новом своем варианте, в новом обновленном варианте. Быстрые обзоры, постоянно обновляющиеся обзоры. Вот поэтому, дорогие коллеги, мне кажется, мы уже все завершили. Я зачитаю только вот последнее.
Therefore, dear colleagues, I think we are completed. Let me read a letter of gratitude. Thank you for highly informative webinar. Thank you for interesting presentation and useful information. Thank you for the conference. Thank you to all the presenters for your work. Dear colleagues, we'll have now to move to our general broadcast, same way we have done it after the first session, and we'll have a final discussion, including our leadership and the official closing of this seminar. And one more thing. Thank you for important conference, excellent presentations. I wish all the presenters and organizers inspiration and patience. Thank you for creativity, bravery and professionalism. Thank you, dear colleagues. Now, please, let's quickly switch to the original broadcast. With the exception of moderators, all moderators, guests, speakers, please stay where you are. Just stay here. Are we interpreted? Are we being interpreted?
Спасибо большое, Александр.
Уважаемые коллеги,
dear colleagues, we are at the final stage of the second International Cochrane Seminar. And prior to joining the general discussion, as I have announced in the beginning, we have a very pleasant event and a pleasant mission, which is to virtually, unfortunately online, present a diploma of an honorable professor of Russian Continuous Education Academy to our great friend, our pediatric department, our pediatric chair, our main clinical base, pediatric department of Tushina Hospital, Dr. Harold Lippman. May I briefly describe Professor Lippman, and then I will pass the floor to our esteemed guests who have joined us. Professor Harold Lippman, for a long time, was the senior medical advisor of the Foreign Ministry of the United Kingdom, and he helped to develop Russian healthcare and cooperated with our colleagues for 35 years. He is a manager of Tushina Trust Fund, which has been created after the earthquake in Spitak, Armenia. The foundation has also assisted tremendously to Bashlyeva Hospital, headed by Professor Osmanov, introduced hospital-acquired infection control, family care, and other innovation. This trust has estimated and consulted the hospitals in management issue. They've opened the first school for pediatric nurses, first in Russia. Princess Diana has visited. I heard about this visit from my senior colleagues, from academician Mashetov, from academician Podubnaya, and my other senior colleagues are recalling this visit with admiration. We've organized training for Russian teachers, for nurses, for pediatric nurses, and issued a number of textbooks. After the tragic passing of Princess Diana, the foundation has introduced the grant to spend 3 months in a London hospital, and starting that time, 56 scientists from Russia and Kazakhstan had an internship there on this grant program. The foundation cooperates with Raisa Gorbacheva Foundation and start training children's oncologists, and Dr. Harold Lippman is working in the preventive cardiology together with the World Bank for development on the decreasing of heart attacks and brain strokes in Russia, and he had developed and taught in Russian the weekly course of preventive cardiology in Ufa. This is just a list, it's a brief biography and a list and the history of our cooperation. And now the floor goes to Nelly Naigusina, the friend of our academy, who is the head of the chair of stomatology, Stomatological University, named after Yevdokimov. Good afternoon, dear colleagues. Thank you for inviting me. And I believe that these 35 years passed as a single moment. But when we talk about Harold, one has to mention his wife, because they are not just spouses, they are people, they are comrades in arms in common cause, and her contribution cannot be overestimated. Harold worked in many different establishments, but his main access was Tushina Hospital. Whenever he came, we've met, and despite the fact that I have left the hospital for a long time already, our friendship continued. And I would like to say that Harold kept this connection. Therefore, it is my pleasure that his merits have been duly recognized, and I believe he will contribute a lot to the development of healthcare. Thank you very much, Nelly, for kind words and for the opportunity to be part of this honorable ceremony. Now the floor goes to Bashlyaev Hospital or Tushina Hospital, the largest base for our pediatric studies, Professor Osmanov. Thank you, Dmitry. Good afternoon, dear colleagues. It is my pleasure today to be here with you and to speak here. This is a very pleasant ceremony, which definitely moves my heart. Nelly modestly skipped the fact that she was at the source of this great process that has been started in 1989 together with Dr. Harold Lippman, and she worked a lot on the equipment of the hospital and in the education, the educational process, which lasted all these years till pandemics in Great Britain. Every year, 2 or 3 doctors have been selected. A special committee from Princess Diana Foundation came. There was very serious selection. There was a competition, and these 35 people, they not just learned there, they mastered new technologies, new techniques, which they are actively introducing in their regions and their place of work. Moreover, Harold Lipman is not just the head of the foundation who organized this internship, but their family, Harold and Nahi, took personal care of all these doctors. They invited them to their house. So they were like their children to them. So, and this is coupled with the opportunity to master the latest technologies. It's worth a lot. Were it not for pandemics, this process would have continued. And it is my pleasure, and I'm grateful to my lot. I'm fully grateful that we are interacting with Harold Lipman since 2002, and the work started by Nelly. It's going under her guidance, and we do believe that we'll have further projects. So, Dmitry, you're right. When you introduced Harold, you said the main thing that he's a great friend of our hospital, of our academy, of our pediatric system. Thank you very much, and thank you very much for this high estimate. Thank you, Ismail, for your statement and your kind words. Dear colleagues, now I have to officially say that by the decision of the Scientific Council of the Russian Academy of Continuous Education, protocol number 8, with us, due to pandemics, it's a little bit delayed. We were hoping to be able to present it in person. We were unable, but the title of honorary professor unanimously is bestowed upon Dr. Harold Lipman. Dear Dr. Lipman, congratulations, and the floor is yours. May I say a few words? For me, it's a great honor to be to receive the title of honorary professor of the Academy of Continuous Medical Education of the Russian Medical Academy. I thank you for your attention. Thanks a lot to all of you, to Nelly, to Ismail, to Professor Ismail Osmanov, to everyone. I'm very happy. Thank you. Thank you.
Спасибо, доктор Харальд Липман, за ваше выступление, за ваши...
Thank you, Dr. Lipman, for your speech, for your emotions. We are honored to have you as our honorary professor. The diploma will be sent by diplomatic mail, and it will be delivered to your home, and I hope it will find worthy place on your wall in your office. It had been a very moving ceremony, and I think it's truly significant that this ceremony is at the end of our Cochrane seminar, because everything Professor Lipman did and everything we are doing is directed to increasing the safety and quality and efficacy of medical care and to the health of our of our patients. Before opening the final discussion, I would like to thank again Professor Karsten Jorgensen for, first, active participation in this seminar. Professor Jorgensen, from beginning till the end, took part in the discussion, group discussion. Therefore, he was listening to all our presentations and the presentation of our foreign colleagues, the representatives of the WHO, the Cochrane representatives, presentations of Russian Medical Academy of Continuous Education. Let me just remind a few words about Professor Jorgensen. Professor Jorgensen started scientific research in Cochrane Nordic in 2002. He was a young elite researcher. In 2013, he became a senior research scientist and doctor of medicine in 2015, chief physician. He's now the treasurer of Danish Institute of Methodology and is part of scientific group for prevention of hyperdiagnostics. He took part as a consultant in numerous researches and the consultant for Danish Health Ministry. He was a deputy director of Nordic Cochrane Center, and as of 2019, he is a director of Cochrane Nordic Center. With his huge support, we have organized the division, which is called now Cochrane Russia, which for already 1 year is functioning in the on the site of Russian Medical Academy of Continuous Education. In 2015, he provided invaluable assistance to our specialists in organization of this branch, and throughout our activity, he provided methodological support and scientific support. Professor Jorgensen, thank you very much, and I pass the floor for the moderation of our general discussion to Professor Lilia Zyganshina. Lilia, the floor is yours. Thank you very much, Dmitry. Thank you very much, dear colleagues. I would like to join the gratitude and express the hope that we will cooperate.
У нас почетным профессором нашей академии. Будем к этому идти, дорогие коллеги. Ну, а сейчас у нас с вами время для общей дискуссии. Вот с первой группой, где как раз работали профессор Карстен Йоргенсен и Диляра наша, и в нашей группе, где мы работали с Марге Рейнап, Всемирная организация здравоохранения, программы EVIPNet, мы подготовили слайды, и мы просим Николая, пожалуйста, эти слайды сейчас показать. И пока сейчас они выходят на экран, у нас другие группы работали. Может быть, кто-то, если можно полностью на полный экран, Николай, вот отлично, да, мы сформулировали, вот это были наши вопросы, дорогие коллеги. Если мы пролистнем к следующему слайду, Николай, пожалуйста, да, то вот здесь попытались мы отразить то, что было сказано. Я по-русски зачитаю. Первая группа о ценности доказательств Cochrane для здравоохранения, для здоровья в целом. Итак, резюме. Важно заручиться поддержкой официальных руководящих органов, Министерства здравоохранения это, для эффективных изменений в системе. Мы помним, что Дании потребовалось не менее 20 лет существования Кокрейновского центра, чтобы реально встроиться в систему здравоохранения и быть серьезным словом и рычагом в ней Кокрейновскому центру. Далее, разработка руководства рекомендаций на локальном уровне на основе международных рекомендаций должна быть, и при этом важно учитывать обязательно локальный контекст и актуальность. Ну и третий пункт из обсуждений в этой группе – продолжать и развивать образовательные программы по доказательству.
And of course, we need to continue develop programs in evidence-based medicine, and we need to use evidence both for students and for practicing physicians. So, dear colleagues, this is what our webinar add to the roadmap of developments of Cochrane Russia. And here you see a short summary of our discussion in English at the bottom of the slide. Now we can move to the second presentation. Nikolai will display the slides on the screen. We haven't received any other slides yet, but unfortunately we are running over time due to a number of technical glitches that we had during the webinar. So if any of you would like to speak, we'll be very grateful. So the question for the discussion was as follows: how can the WHO concept of evidence to policy in health can be applied to Russian healthcare? What are the plans, achievements, and barriers? Margaret Reynolds was the moderator of our discussion, and Dmitry and I were the co-moderators. So the summary of this discussion is as follows. Kazakhstan is a leader in EVPNet Europe projects in NIS countries, and we're very lucky to have our colleagues from Kazakhstan participating in our group discussion. So Kazakhstan is a leader in EVPNet Europe projects in CIS countries. Situational analysis has been developed and is ready for publication. And of course, we have similar issues when it comes to implementation of this initiative, and our colleagues talked about a lot of human resource problems. We have a significant shortage of people. The experience of Kazakhstan in European countries is useful for Russia, and it will be used in Russian, and we will invest all our efforts into that. And then Margaret shared her experiences, and that competition countries becomes a driving force for successful evidence to policy development. So you see the summary of our discussion in English at the bottom of the slide. If we need to add anything, Margaret, please add whatever you think should be added. So I am waiting for your feedback, for your comments, so you can share your thoughts with us online. And for this, you can use a microphone. Oh, it should only be the speakers, but okay, Karsten can also speak up. But while we are waiting for people to gather their thoughts, I would like to read some comments we got on the chat. People are thanking the organizers and the speakers for wonderful presentations. Glory to the medical science. It's great that the medical science continues to develop due to creative people who are very passionate about it. Thanks to our teachers and mentors who were at the start of all of these initiatives. And I'm very pleased to tell you the statistics for this meeting, and I would also like to thank the technical support for all of their help. And of course, technical glitches are fortunately unavoidable, but our technical support, they did a marvelous job. We had people here from 207 cities. We had 152 specializations of physicians, and overall we had 1,498 people watching. I'm sorry if I made a mistake in one of the numbers. I'm just trying to read it off the screen. So 1,498 people connected to us online. 2,507 people registered to participate. Olesya Miroshnichenko is our technical guru, and she confirms that the statistical information was correct. Thank you very much, Olesya. And I also wanted to thank our volunteers. I would like to thank our translators. They are the invisible army who did a lot of work. I would like to thank Dilara Nurmohamedova. Dilara is currently working in Finland, and she always volunteers her help and assistance to all of us. She also helped us to translate all of the slides into Russian, and she did it within the shortest possible time. So thank you very much, Dilara, for all of your help and assistance. I would also like to thank Aziara, who is a volunteer social media manager of Cochrane Russia, and she contributed a lot to the fact that we're all here today. And I would also like to thank the management of the Russian Academy for Continuous Medical Education. We found a new home in the academy, and we have a lot of new ideas. And of course, our journey will not be easy, but I hope that we'll manage to overcome all of the hurdles together. Thank you very much, dear colleagues. Your support is truly invaluable. And it is a great pleasure for me to express my heartfelt gratitude to all of you. And with this, I give you the floor for the final remarks. Distinguished colleagues, we had a very busy day today. We had a full day discussing the most relevant issue. When it comes to our work, regardless of our medical specialization, we are all interested in the topic that we were discussing today. It just means that the topic we discussed today was extremely relevant to all of you. So we need to utilize all of the tools available in Cochrane Library. Different countries, of course, take a different part in this process. Different countries have different experiences, but the fact that we are busy getting experience is absolutely delightful. Today, we have guidance in order to make rational and well-informed decisions in healthcare. We have EVIPNet, we have clinical guidelines, we have analytical reviews, we have the actual Cochrane Library, and we have many other tools that we discussed today. Well, the fact that we have all of these resources is great, and we need to utilize all of these resources to their full extent. Today, we talked very passionately about this issue, and we need to preserve this passion in introducing all of these tools into our day-to-day practice. I would like to thank all of our audience. It is not only a large audience, but it is a very interested and highly professional audience. We received many different questions. Some of them were straightforward. Some of them were very complicated. We had very good group discussions, and I would like to thank the experts who were moderating group discussion. I would like to thank everybody who was invited to speak at this webinar today. I would like to thank the World Health Organization. I would like to thank Margaret as a speaker, and I would like to thank Dr. Melita and Yelena Yurasova. We collaborate with WHO very effectively, and we're very grateful for the possibility to discuss all of the issues at the highest possible level. I would like to thank all of the representatives from Cochrane We are very interested in expanding the collaboration with Cochrane because we do have a number of issues that we need to resolve. We had a very productive workshop today. This is the second event. It is a scheduled and planned event, and we are planning to take this topic further and to discuss it during future events. I would like to thank our organizer. I would like to thank the representatives and the director of Cochrane Russia, Lilia Zidanchina. She is truly passionate about her work. You probably saw it during the conference today. You saw her true passion, and I believe that we all spent our time with the most benefit. Thank you very much, Irina. My mission is to wrap up our webinar, but before I do that, I would like to give you a brief message. When it comes to the development of evidence-based medicine in this country, it was going hand in hand with the development of clinical pharmacology. Clinical pharmacologists, together with oncologists and cardiologists, became the first adapters of evidence-based medicine. That's why in many universities in Russia we have a department of clinical pharmacology and evidence-based medicine. We have many other departments in medical universities that offer courses in evidence-based medicine. It is very important to bring evidence-based medicine to physicians through educational programs. They should learn about it during their specialization, internship, and through continuous medical education. In our institute, we've been doing it for a long time. Recently, we launched a department that evaluates efficiency of healthcare technologies. A reference standard for any evidence for us is, of course, Cochrane systematic reviews. They are at the top of the evidence-based pyramid. All of the issues that we touched upon today, and we talked about implementation of evidence, or using evidence to make informed clinical decisions, we are going to continue doing everything to advance this field. And I would like to thank Margaret for the invitation to participate in the Kazakh project, maybe in collaboration with WHO. We will also work on increasing the availability of Cochrane Library for our students, for our interns, for our postgraduate students, and for all of the doctors. Our roadmap includes further development of Cochrane Russia under the aegis of the Russian Academy of Continuous Medical Education. We do a lot of educational events. The Ministry of Health of Russia wants to stay updated on the latest Cochrane systematic reviews, especially when it comes to COVID-19. Therefore, that is something that we also work on. And I would like to conclude this webinar by talking about young doctors. Recently, we polled our postgraduate students and our interns. We polled our young doctors from different cities in Russia. We looked at 5 large medical universities. We got a lot of responses from our medical students, and I was very happy to see these responses. First of all, our young doctors know about evidence-based evidence. So 1/3 of them know about Cochrane systematic reviews, and the majority of our young doctors said that they want to learn more about Cochrane systematic reviews, and not only they want to learn more, they want to contribute. They want to contribute to writing these reviews or to helping translate these reviews into Russian. And that means that our new doctors, the new generation of doctors, are ready to accept this method, and they will actively use this method for the benefit of our patients. I would like to thank the management of Cochrane. I would like to thank the World Health Organizations and the World Health Organization office in Russia. Thank you very much, Professor Podubna, for your efforts in the area of international cooperation. I would like to thank our organizational team, our IT support team, and I would like to thank our department for the translation of evidence-based evidence, Professor Ziganshina and Assistant Professor Yudina, for all of their hard work. Distinguished colleagues, I would like to thank all of you for being patient, for participating in our group discussions, and I think we will see you again during our traditional December Cochrane seminars. I think they will continue, and maybe in the nearest future we are going to have them face-to-face. Thank you very much.